other diseases are also screened together. This I will not highlight here. There has been a cumulative rise of the screening of diabetes in the state, and there has been many joint wheel visits to motivate the staffs to also monitor how things are going on. And the state has come up with some innovative concepts like the diabetes support group, diabetes peer group, where they give advice, discuss among themselves, and also raise funds for patients having complications with diabetes, like diabetes with stroke, giving palliative care, giving kidney failure with diabetes. So such initiatives have been started in some of the health and wellness centers. Patient iCards and follow-ups are being given. Diabetes iCards are issued to the patient where we give the risks and signs of hypoglycemia. And of course, in this state where there is a turmoil and when there is always a strikes and burns, this is one card which is helpful for the patient to remind of their need for their diets and drugs. However, there are still challenges and mitigations. Challenges are there, like we have limited healthcare infrastructure. The geographical terrain in the hill districts is very far to cover most of these areas, and some of the communities are even are not very much agreeable because of their need to spare the time, and they thought that there's no need for the health checkup. And there's a need for the public-private partnership, and there's no more need for the whole state and also the Northeast in general to link up with the different health institutions, the government and non-governmental organizations, the medical colleges, and all the who are practicing diabetes under this forum. And it's my humble appeal that we all integrate together to bring down the rise of diabetes. So these are some of the way forward in the preventive healthcare. So my key home message is lives of people by preventing complications of diabetes like kidney failure, stroke, and heart attack. And we all need a collective effort which is required for this success. Thank you. Thank you all.
Thank you, and congratulations, Dr. Y. Premchandra, for your excellent presentation of NCD program in Manipur and the community-based screening of diabetes. 16.5% among the male and 13.6% among the females. High figure, and it should ring the bell, alarm bell for all of us.
So actually, we have not done a very systematic sampling study for this study as such, but from the monthly reports which we are getting, right now the rural population is the gap is quite narrowed now. It is quite prevalent, almost similar, and because the migration effect is very much in Manipur, the technological impact is very much in Manipur, sir.
Okay, thank you. I give the mic to my co-chair person.
I am totally in sync with what my co-chairperson has just said. Dr. Prem Chandra has covered in entirety. But then there may be questions in the mind of the, of the floor. So questions are invited now.
Okay. So that is again depend upon the different diurnal rhythm of the different hormones of the body. Say when we go about sometimes patient we found that the fasting they take in the morning, they take food very late. That is not acceptable. When we say it should be in the morning period, preferably say 8, 9 is the right time to take for a diagnostic criteria.
Network, yeah. I think some network issues. Network issues, still your slides are not clearly visible. You are visible very much. Please, yes.
Can I go ahead from if it is visible or?
Slides, yes. Now it's visible. Now it is visible. Yes.
Thank you, Chairperson, sir, for the kind introduction. And at the outset, as Secretary of Northeastern Diabetes Society, I congratulate Manipur chapter for holding the conference. Though in difficult times, in hybrid mode, we are doing it. But still, I convey my thanks for the successful holding of the conference. So I'll be talking about the castle replacement. First, we heard about screening for diabetes. That is a Herculean task. And from that screening, we come to know that it's a very difficult task to screen for diabetes alone. But now I'll be talking about the castle replacement, which is much into the future. But currently, there are limitations because of availability and maybe cost also is a factor, and maintenance of the replacement is very difficult. So, nonetheless, we should know what is going on around the world in terms of diabetes management, especially castle replacement. So we know that India is harboring a large chunk of population, diabetes population. 101 million adults in India have diabetes. This is according to our Lancet indirect ISCOM or indirect study. And 124 million diabetes. So these are a huge number. And 101 million, more than 1 million type 1 diabetes is also there in India, and that makes India one of the number one diabetes, type 1 diabetes in terms of number of people, not by US law. And we Indians, so we know that onset of diabetes is earlier compared to the Western parts, and a lot of other factors are also there. Insulin resistance is higher, cardiovascular risk is higher, and insulin secretory effects are also there. So while talking about development of type 2 diabetes, we know that in the natural history, from normoglycemia to pre-diabetes to diabetes, the insulin secretory defects starts much early, and at the onset of diabetes, around 50% of the beta cell mass is lost. And insulin resistance starts to increase from a pre-diabetic stage and reaches its plateau once diabetes is diagnosed and remains like that. But the beta cell decline is a progressive thing which keeps on happening as the diabetes goes longer. This is about type 2 diabetes. In type 1, we know that insulin secretory defect is the primary area where we talk about, and to know about beta cell regeneration, we have to know the molecular pathway for controlling the human beta cell proliferation, how insulin beta cells proliferate and insulin secretion happens. there are various pathways. One of the things we need to remember is that the pregnancy time, the beta cell proliferation is quite high, and during insulin resistance also, the beta cell proliferation is there. So in pregnancy, placental lactogen and placental various hormones, they work through the JAK2, and the protein which is released, they work at the level of PI3K, phosphoinositol 5-biphosphate 3 kinase pathway, and triggering the IRS1 and insulin-like growth factor 1 receptor, and then the step proteins, they go in from cytosol to the nucleus, and then they lead to insulin proliferation or beta cell proliferation. In another pathway, by OPG, osteoproteogenins from the bones, and they work at the level of the rank, and then AKT, and that pathway also leads to proliferation of the beta cells. Another is the SERPIN B1, which again in a different pathway, they GSK and PRK pathway, they act and also lead to proliferation. There are other pathways like GLP-1, wherein exendin 4, and they work at the level of the GLP-1 receptors, and leading to again phosphorylation of the PI3K kinases, and then going from cytoplasm to intranuclear to cause proliferation. And what happens inside the nucleus is one inhibitory protein called DYRK1 alpha that causes inhibition of the dephosphorylation, and the protein comes out to the cytosol as NFAT, and there the various molecules are being targeted to devise DYRK1 alpha inhibitors, wherein INDI, HARMIN, 5-IT, aminopyrazones, these are the molecules where they may act as beta cell regeneration can be possible. While talking about beta cell regeneration, what we mostly know is the islet cell transplantation, which is quite old. It was started way back in 1999 and refined to the Edmonton protocol, where they use less of steroid-based immunosuppression and used monoclonal antibodies. But there were limitations, and then post 5-year, that was not a very hugely successful program, and so it cannot be translated to the general masses. So in beta cell replication, there are various local and circulating factors. Local factors, if you look into, it will be based on the pancreatic islets, macrophages, endothelial cells, and beta cells. Various factors like IGF-1, hepatocyte growth factor, connective tissue growth factor, TGF-beta, epidermal growth factor, platelet-derived growth factor. A lot of things are there, and they in turn lead to beta cell replication. These are the local factors which is based on the pancreatic islets. And also circulating factors also will be responsible from the slide previously showed. You can understand that from the bone also. OPG is there, osteoproteogenin, and WISP1, and from liver, IGF-1 to SERPIN B1. Glucose is also trigger for beta cell replication. GLP-1 from the gut, and placental prolactin, placental lactogen, and placental growth factors also will lead to beta cell replication. Nevertheless, we should not forget that food from which glucose is derived, that is also one of the triggers for beta cell replication, so that insulin secretion is there. So based on that knowledge about how insulin secretion happens and what are the pathways controlling the insulin secretion, there are various synthetic compounds which may promote beta cell replication. Various modes of action will lead to insulin replication or beta cell replication, like increasing the intracellular cyclic AMP levels by pharmacological agents like NECA and UK432097, inhibition of the adenosine kinase activity or increasing the extracellular adenosine. Various pharmacological agents work at the level of the beta cell replication. Vildagliptin, sitagliptin, by inhibiting the DPP4 enzyme and enhancing the GLP-1 activity, though it's in a physiological level, not as the GLP-1 receptor analogs, where in supraphysiological level the enhancement is there. They also will lead to some beta cell replication will be possible. Harmine, leucitin, CC401
by inhibiting the DYRK1 alpha mediated effects, which is an inhibitory protein. If we are able to produce molecules where DYRK, the inhibitory protein, is stunted, then definitely the insulin replication will be enhanced. Various glucagon receptor proliferation, like monoclonal antibodies, GR monoclonal antibodies, also will lead to activation of the beta cell replication. Why the failure of the islets occur? The insulin depletion or the insulin resistance, they happen because of two factors. One, the insulin resistance at the level of the skeletal muscle, wherein the insulin will not be able to push the glucose for the skeletal muscle to use it, so the decreased glucose uptake is there. At the level of the liver, there is increased glucose overproduction, and adipose tissue, there is increased lipolysis and inflammation. And beta cell, pancreatic beta cell mass loss also is there, functionality and the beta cell mass also decreases in course of time, and there is increased alpha cell function. Dedifferentiation is there, so those sort of things will lead to islet failure in type 2 diabetes also. And there are various cell-based therapies for type 2 diabetes. For type 1, as I mentioned, the islet cell transplantation was a program, Edmonton protocol was followed for type 1 diabetes, but for type 2 diabetes, that was not very much tried. And currently, stem cell-based therapies are evolving, and they are looking into areas where beta cell regeneration can be possible by doing immunomodulation or genetic engineering of the stem cell derived beta cells by various processes, and encapsulation of the beta cells also can be possible, and then the beta cells can be revived. Earlier, we know that islet whole pancreas transplantation was tried, but scarcity of donors and aging population, reducing the functional outcomes and requiring specific isolation strategies, and also the requirement of very strict immunosuppression post transplantation are the limitations. Then alternative xenotransplantation of porcine islet was tried, but again a potential solution to the limited donor supply, and some xenogenic immune responses may happen and make it difficult to fully implement. then came the human stem cell derived beta cell transplant replacement, which is a quite promising area. Though personally I have no experience about using stem cell. A couple of years back, stem cell therapy came to this part of the country, wherein they promoted for some neurological disorders, and for diabetes also had some, but I did not have experience using that. But still, let us see how it can help. Some of the recent findings showing different devices used for islet transplantation. Most promising was for the Fiorina et al. In 2012. They used immunomodulation strategy, and transplant site was the liver for the islet cells, and species they took from human species, and what outcome was looked into was reversal of the type 1 diabetes. And there are few animal models in mice and dogs, and few of the recent macro encapsulation devices where they were injected into the subcutaneous tissues. Source was again human source, and they increased the C-peptide levels, and both fasting and stimulated C-peptide levels. Shapiro and Ramsey et al. In the 2021 period, they looked into studies like this. While talking about stem cell therapy, one of the important areas is to do the immunomodulation or the immunoadaptation, because these cells are again subject to immune destruction. So we need to target various regulatory T cells or Tregs, and these are the CD4, CD25, and FOXP3 are the specialized subset of T cells which help maintain the immunotolerance. So their depletion can lead to immune-mediated graft loss. So we need to maintain a steady level of these Tregs so that the graft rejection or the immune cell rejection is not there. So various trials are going on, Treg based clinical trials. Polyclonal Treg therapy for beta cell transplantations are going on, and there are certain other encapsulation techniques. These are again genetic engineering or biotechnology derived processes, wherein the these stem cells are again encapsulations is done with biocompatible membranes and with immunoprotective barrier in various sheets and meshworks, and then they tend to stay longer in the system for better action. Humanized mouse models are there, or MSC co-transplantations are also being studied. Some of the beta cell regeneration current progresses like beta trophins, which is a soluble factor or replacement therapy. These are based on beta trophin increases the beta cell mass in mouse models, and but in human model it was not good enough to see viable increase in the beta cell mass. Insulin receptors also, wherein in mouse model they have looked into liver specific knockout of the insulin receptor and through ERK pathway, and again this is not being studied in the humans. In animal study it is there. Glucagon receptor or antagonist antibody, this has been tried in the mouse model, and phase 2 of human trial is going on. But again, risk of alpha cell hyperplasia might be again a safety concern in this sort of things. there are other, pathways are also being, looked into, the transcription factors like PDX1, NGN3, PEX4. A lot of pathways have been tried for beta cell regeneration from stem cells, and but it's yet to see the full success. So what we can say is that beta cell regeneration currently it's in a initial stage of development to say whether it is hugely successful or not, or can it be explored in the vast population. If not the vast population, in a selected group of population, diabetic population, it can be tried. This type of beta cell regeneration is mostly beneficial for the type 1 diabetics, but again it can be tried for the type 2 diabetics also. And in this particular slide, we can see that the stem cell based therapy, where they from pluripotent stem cells differentiation was done in 10 days period to pancreatic endoderms, and this macro encapsulation was done so that it can be there in the system for a longer duration and injected into the subcutaneous tissue. And in another pathway where from pancreatic endoderm, they were again direct differentiation was done for a period of 3 weeks, and then they made to a mixed pancreatic cell containing the beta cells, wherein all the cells will be there, alpha, beta, and somatostatin producing cells also will be there. And they were injected naked into the intrahepatic tissue. Intrahepatic injection was done, and again clinical trials are going on. So other stem cell based beta cell regeneration have been tried with embryonic stem cells or induced pluripotent stem cells, but again there are limitations like unlike donor islets, the stem cell derived from beta cell are not limited by the donor shortage, or labor-intensive isolation procedures. So it can be used, and reduced immunosuppression need is there because of less immune rejection and reduced need for lifelong immunosuppression with the induced pluripotent stem cell derived from the patients. So this is a more pragmatic idea, I'll say, for a successful program for beta cell regeneration. In animals, definitely beta cell regeneration is more suitable, and in young animals, within few weeks, the regeneration is very fast, and in humans also, it's very short-lived. So, to make it for a longer duration, for its action for a longer duration, we need to do little transdifferentiation and beta subtype interconversion should be done. So for a successful stem cell therapy, there are 4 areas which we need to look into, like systemic immune therapies for vascularization possible, and positive effect on the beta cell, endogenous beta cells, and chronic systemic treatment may be required, or graft retrieval, no graft retrieval may be there. So here, monoclonal antibodies targeting the cytokines will be used, and another way is to macro encapsulation it, the whole cell with a macro encapsulation, so that it gives an immune shielding, and no immunosuppression therapy may be required in those situations. But graft retrieval is possible in that cases, but poor oxygenation or amyloidosis may happen when we do encapsulation. So micro encapsulation is there, wherein the immune shielding will be there, and the individual monoclonal antibodies will be microencapsulated, and there also, if we do encapsulation, chances of amyloidosis is still possible in whether we do microencapsulation or macroencapsulation. And another area is modification or co-transplantation, wherein we try to increase the longevity of the beta cell by modification of the immune-invasive malignancies and other factors. So overall, there are a lot of strategies for beta cell therapy. Mixed chimerism, hematopoietic stem cells, bioengineering approach, wherein the biocompatible semi-permeable membranes or devices with the stem cell. Basic stem cell will be there, but how to incorporate into the target patient, that we need to look into for prolongation of the action of these stem cells, so that they in turn lead to beta cell regeneration. Treg therapy is there, blastocyst complementation for islet regeneration, control beta cell proliferation, alpha beta cell trans differentiation. So lot of emerging alternative strategies are there for beta cell therapy, but again, some advantages and disadvantages are there, but it's not really, not very far that we'll be able to see good results with beta cell replacement therapies. Recently, one of the updates have come that with a new DYRK1 alpha in combination with GLP-1 receptor agonist and transforming growth factor TGF beta, they are being tried and showing promising results. That will in fact increase the beta cell mass, and if it becomes successful, then definitely we'll be able to see a lot of people with type 1 diabetes having benefits with it, and also type 2 diabetes patients. So key takeaways will be beta cell replacement therapy by human islet transplantation is the only way of replenishing the beta cells. So far, though facing extensive challenges of the limited donors and the intense immune rejection happens. So that is one thing. And beta cell regeneration, it holds a great promise in the future, but still it's in the preclinical evaluation. And some phase 2 trials have happened with some of the stem cell therapies. And most important advantage of beta cell replacement is that it makes it possible to near normalize the glycometabolic control. So if we are able to revive the beta cells, then definitely it is possible to correct the insulin secretory defect, and also the insulin resistance defect also can be to some way it can be controlled. The reason lies in the highly organized structure of the islets that allow functional interactions, and insulin therapy, even with the most recent technologies, cannot reproduce this level of complexity. So there are limitations, we have to understand that, but it's not a, completely, negative way to think that it will not be successful in the current, in the recent future. So we should be hopeful that some of the technologies, areas what we have discussed today, will definitely click, and then we'll be able to have substantial, replacement therapies for potential cure for type 1 diabetes. The previous limitation was that if whatever technology we use, insulin-free period is just a period of 5 years. After that, again, insulin injection will be required. So if it is able to prolong that period for up to 10 years or more, then it will be
successful program. About the ability to induce beta cell maturation from ESC and iPSCs may represent a solution to the organ shortage and also creation of encapsulation devices for islet encapsulation. iPSCs will be more suitable because we'll be taking the cells from the pluripotent stem cell from the the patient himself. So definitely it will be more suitable because immunosuppression will be less required. So those are areas where it can be explored, and things are going in the right direction, so that we have in future we get definitely successful beta cell replacement regeneration. Thank you so much for the patient hearing. Over to the organizers.
Thank you very much, Dr. Rupam Das. We have listened from you a very exciting topic, future of beta cell replacement. You have covered all aspects like embryonic stem cell transplantation, then immunomodulation, and then encapsulation techniques also, and some growth factors and new pharmacological agents. So do you envision that some genetic manipulations like CRISPR will also be helpful in this thing, beta cell regeneration?
Yes.
Okay, I share the mic with my co-chairperson.
Dr. Rupam, congratulations for the nice talk. All this while we have been very, very restrictive in terms of our perception for a diabetic patient, to be honest. Diabetes diagnosed, and then we think about oral drugs and some insulin. I think that is what we have been practically in the field. This talk today, this morning today, has given a new insight into the, what I may call it as a horizon of hope. Because beyond drugs, oral drugs, and some insulin, is there any hope for the diabetic patients? I think Dr. Rupam's talk has given that answer. Despite the initial hiccup, technical hiccup, I think Dr. Rupam's message is very loud and clear. But the thing is, Dr. Rupam, our esteemed delegates may have some questions, some clarifications they might seek. So please stand by. I would like to open this session for questions and any query from the floor. Okay. Dr. Rupam, you said something, if I heard you right. Pancreatic transplantation is one. Islet cell transplantation is another one. And then the talk today was centered around beta cell transplantation. So what are the kind of advantages going for a total pancreatic transplantation, islet cell transplantation, and beta cell? If you give me some time, I may add that when we are going for the beta cell, aren't we forgetting or ignoring, to put it in that way, the role of the alpha cells, delta cells, and so also the pancreatic peptides? They also have a very good role in the overall maintenance of the glucose homeostasis. So by going for the beta cells, perhaps we may get some advantage in case of the immunogenicity, but going for the islet transplantation would be more theoretically, at least to my perspective, would be more meaningful. What is your take on that?
Yeah, I mean, for stem cell therapy also, if we do, it has to be differentiated into, in one of the slides I have presented that the mixed cell population has to be done and then injected into the hepatic vein, so that we get the whole cell types. Otherwise, generally for a normal non-diabetic patient, the cells talk within themselves. Alpha, beta, and delta cells talk within themselves and makes the glucose control very, balanced. But if we just give only the beta cells, the chances of hypoglycemia will be high, because in times of low sugar, if alpha cell is not there to counteract, then definitely hypoglycemia incidences will be increased. So whatever, stem cell therapy we try, because islet cell, we know that islet cell transplantation, whole islet transplantation, it's a very tedious thing and a lot of immunosuppression is required. But with stem cell therapy, that has, refined quite a bit. And just that the mixed cell types should be promoted so that we get a proper balanced glycemic control.
Right. If I may be allowed to sum up in a nutshell, regulation is a key word in your entire presentation. And regulation of, number one, legislation. That is required. Because if you are talking about, pancreatic transplantation, it will be followed up and the guideline will be as per Transplantation Act. But if we are going with stem cell, the algorithm is totally different. We'll be going for the drug route kind of algorithm as far as the regulation is concerned. That is number one, regulation. And number two, you have very nicely elucidated in your presentation that immune regulation. I think the success, the outcome, ultimate outcome of this transplantation process, the beta cell or the islet cell will be modulated by the alteration of the immune. And there comes the role of the encapsulation that you have very nicely elucidated in your talk. If there is no more question from the floor, can I? Yeah, thank you, Dr. Rupam. Greetings from Manipur.
Thank you.
And once again, for the time that you have given for all of us. Thank you very much.
Thank you.
Organizers? Second. Connector opera. Next one, connector opera. Ang kanang di mukut ki CD do mukut.
Hello? Hello? Oh. Dr. Mukut Roy? Dr. Mukut Roy? Am I audible?
Yes, sir. Sir, am I audible?
Yes, yes. Yeah.
Thank you, sir.
Okay. Thank you. Thank you for your presence. Our next presenter, our third presenter for the first session is Dr. Mukut Roy. Dr. Mukut Roy is an DM in endocrinology. His present designation is consultant endocrinologist and is in charge of endocrinology division of the Tripura Medical College, Tripura. He is a professor of medicine at Tripura Medical College, a fellow of ISCM API, a fellow of Royal College of Physicians, Edinburgh, and a former joint secretary of Northeast Diabetes Society. And he had multiple national and international publications, and he's a reviewer in multiple peer-reviewed national and international journals. Today, the topic allotted to him is precision approach to atypical diabetes. So, I hand over the rest of the time to Dr. Mukut Roy for his presentation. Yes, sir. So you can take your time, sir.
Thank you, Chairperson, sir, for such a nice introduction of myself. Actually, my speaking on a precision approach to the diabetes. So I'll just take some time just to share my slides. And the organizers give me the option for sharing the slide.
Good morning, Dr. Mukut Roy. The time allotted to you is 15 minutes, please.
So is it visible, my slides?
Not yet, not yet.
Is it visible, sir, my slides?
Not visible.
Not visible?
Yes, now please. Coming. Yes. Yes, now it's visible, your introduction.
Your slides are not moving, please.
Automatic arrest ആയിട്ടില്ല. Arrest ആവാൻ പറ്റില്ല. Disconnect करूँ. Disconnect करूँ. हाँ.
Organizers, hello. Can we, if he's having technical problem, can we go to the next session because time is running out, and make him come after some time? Organizers, please consider this point. If Dr. Mukut is having some technical problems, can we switch to the next speaker? Organizers, or next session, I should say.
Yes, we have only 3 speakers for this first scientific session, so we can
Yes.
now end this session.
Dr. Mukut has got some tech.
speakerꯒꯤ ꯁꯤꯒꯤ ꯌꯥꯎꯗꯦ ꯑꯔꯨꯝꯗ ꯑꯗꯨꯗꯣ ꯁꯤ ꯍꯥꯟꯅ ꯀꯧꯔꯣꯕ So we'll be starting the second session today. The topic is a very important one, pregnancy and diabetes mellitus. And we would like to ask the second speaker first. Topic is metformin in pregnancy. The speaker is Dr. Fiva Cordor Nonglet. She is specialist in Civil Hospital, Shillong, Meghalaya. Completed DM from UCMS, New Delhi in the year 2024. Areas of interest, diabetes, endocrine hypertension, pediatric endocrinology, and publications, many publications. So I request Dr. Fiva Cordor to give your deliberation. Time allotted is 15 minutes with 5 minutes discussion.
Am I audible?
Yes.
Am I audible?
Yes, yes.
Thank you, organizers, for giving me this opportunity. I will just present my slides. So the topic given for me today is metformin in pregnancy. Coming to the background, metformin, as we all know, is an oral biguanide. It has been used in the treatment of hyperglycemia in pregnancy since the 1970s. And as per the feedback taken from the patients, it is highly acceptable because of its cost, because of its oral intake, as well as the safety profile. However, as per the studies done, to date, the evidence regarding the safety of metformin in different cohorts is conflicting. I will be taking you through all the various conditions for which metformin is being used in pregnancy, and as well as what are the long-term outcomes and effects of metformin. So there's a lot of confusion, as I have said earlier, and this is also seen from this slide, as we can see that the society recommendation for the treatment of gestational diabetes and the recommendation for metformin varies. ADA and ACOG, they recommend metformin as a second line, and that too for those patients, ADA says for those patients who cannot take insulin, and it should not be used in women who are having hypertension or preeclampsia or at risk for IUGR, based on the evidence of small for gestational age and decrease in the birth rate of certain population of neonates. The ACOG also endorses the same. It says that metformin can be given to women who decline or cannot take safely or cannot afford insulin. Society for Maternal and Fetal Medicine, however, recommends metformin as the first line. NICE also says that metformin can be given if there's mild fasting hyperglycemia. And Diabetes Canada says that metformin is an alternative first line in patients. However, whenever we recommend or whenever a patient asks for metformin, we should present them with the available data, and they should also be aware that metformin crosses the placenta, because of which it can have effects on the fetus which we may not be aware of right now. So what are the points when we consider for the use of metformin? What are the common clinical settings for the use of metformin during pregnancy? First is it could be type 2 diabetes mellitus, gestational diabetes mellitus, for which many studies have been done. PCOS, patients have been taking metformin, and they have been used in this cohort of patients, and some of the populations have continued using metformin after pregnancy. However, there are certain things that we have to keep in mind. The therapeutic dose of metformin in studies is poorly defined, ranges from 500 to 2,500. Some have gone up to 3,000. And there is a transplacental passage of metformin. So metformin can pass from the placenta from Am I audible? Sorry for the interruption. There was some problem. So when, again, we'll reiterate, there's consideration on the use of metformin, the one which we call passage of metformin, because it can pass from the placenta, from via the maternal circulation to the fetal circulation, and metformin is transported via organic cation transporter. Now, why is metformin useful in diabetes mellitus as well as in other conditions? The one which we are going to discuss out here is because pleiotropic action. As we can see from this slide, metformin has got physiological action on the gut-brain, on the immune cells, on the adipose, as well as on the gut microbiome. What happens in patients and metformin are known to reduce weight gain by acting on the gut-brain axis regulation, controlling appetite and satiety. It's also in pregnancy is immune dysfunction, especially in patients who have diabetes, and it's a chronic inflammation. Patients taking metformin have decreased decreased CRP, so this decreases the inflammation. At the same time, because of pregnancy as diabetes, as development of insulin, and leading to hyperglycemia and oxidative stress, metformin has got a beneficial by increasing glucose uptake, reducing glucose metabolism. So it acts as an insulin sensor by increasing the insulin secretory regulation and signaling. Metformin also has effect on the adipose tissue by increasing the lipid acid metabolism which is beneficial in cases of gestational diabetes because there's a dysregulated adipokine function and lipid metabolism. On the gut, there is reduced microbial diversity as now we are more concerned about gut microbiota and with increased gut permeability. Metformin increases the short-chain fatty acid. It improves the beneficial bacteria, decreasing gut dysbiosis. How does metformin act at receptor level? As it is transported by organic cations, CP3. And since this is positively charged, it enters into the mitochondria and it is taken up, there will be increased production of ATP, increase of activity, and this will intake as well as increase insulin sensitization. At the same time, because of the effect on ATP kinase increase or activity, there is effect on decreased gene expression and decreased metformin. Now, this has got beneficial as sometimes, although metformin is found in equal concentration in the placenta, sometimes 50 to 100% of the maternal concentration, but still we don't see any effect on the fetus, especially in the early stages, because in the early stages of embryogenesis, there is decreased organic cation transporters because which metformin is taken up into the cell. So as an effect, there is also decreased mitochondria in the embryo, because of which we don't see any effect of metformin on the organogenesis, proving that it is safe and teratogenic. However, in the later stages of pregnancy, the placenta expresses a lot of organic cation transporters. So there may be effect on the placenta, and there may be effect on fetal programming, as well as because metformin has been linked to hypopopulation, decreasing the bioavailability of methyl donors. So there are concerns that could affect the baby in the long run. So coming to metformin and gestational diabetes, the first and the most important study, this is a very busy slide, but we will be discussing the important ones. So Moore et al. In 2007 was one to study metformin and gestational diabetes. The number is only 62. And they compared it with insulin. The dose of metformin was 1 to 2 grams, and the gestational age at inclusion was 24 to 30 weeks. They did not find much difference in the rates of cesarean delivery and birth weight in terms of neonatal outcome and other neonatal outcomes. However, the most important study that was done for metformin and gestational diabetes is the mixed study. This was a study which is done in Australia, and they had 2 centers, and they recruited 751 patients, out of which 373 were allocated to metformin and 370 were allocated to insulin. So what they found was there was a decrease in the gestational weight. However, there were concerns regarding increased preterm births. But the other favorable outcome that they found was there was a decrease in neonatal hypoglycemia. The other parameters related to preeclampsia and the neonatal parameters related to birth weight, large for gestational age, was not that significant between 2 groups. A recent study which was done in 2021 in Spain, they studied 200 patient mice to metformin as well as insulin, and the dose of metformin was ranged from 425 to 2,550, showed that metformin use was associated with decreased cesarean section and decreased gestational weight gain. However, the outcomes for other parameters were similar. Now, this is a systematic review and a meta-analysis. The most recent one that was done, they studied 24 studies, out of which 17 were quantitative analysis and 7 were qualitative analysis. In this study, it was shown that metformin lowered the risk of pregnancy-induced hypertension, large for gestational age babies and macrosomia, and there was decreased risk of neonatal hypoglycemia and NICU admission. However, metformin did not increase premature delivery, preeclampsia, cesarean delivery, or small for gestational age, which is reassuring because metformin as endorsed by other societies, can be used in GDM and in mild hyperglycemia in pregnancy. Now coming to metformin and type 2 diabetes mellitus. As we know, type 2 diabetes mellitus has got a lot of effect on the baby as well as on the mother. So the most important study where they have done is the MIGHTY trial. They enrolled 502 patients and they randomized the patients to either metformin or insulin. And they compared metformin with insulin and placebo with insulin. The gestational age at inclusion was 6 to 22 weeks. So what they found in this study was that the rate of cesarean section was lesser in those patients who were randomized with metformin as well as gestational weight gain. However, there were concerns about birth weight as well as small gestational age, because it was found that the neonates who were exposed to metformin had lesser birth weight and they had more small for gestational age. Now, this has been linked to because metformin predominantly shifts the cellular metabolism from an anabolic to a catabolic state, and it is also known to cause calorie depletion by suppressing growth and development and the transmission of nutrients. So this teaches us to be cautious, that in order to prevent macrosomia, we should not be too aggressive in treating patients. We should find out who are the cohort of patients who will benefit the most from metformin. So the outcome of the study was that there was no difference in the primary composite neonatal outcome between the two groups. However, metformin-treated women had lower levels of HbA1c as expected, and metformin-exposed infants had slightly higher incidence of neonatal jaundice and small for gestational age. Now coming to metformin and obesity, as we all know, obesity in pregnancy is associated with greater mortality and morbidity. There is increased pregnancy loss in obese patients, preterm deliveries, hypereclampsia, as well as gestational diabetes mellitus. So there was an interest whether metformin can reduce the rate of gestational diabetes mellitus as well as the other outcomes. At the same time, for the neonate, we also know that gestational obesity is linked to fetal macrosomia as well as the risk of stillbirth. There were two important studies that were done, the EMPOWER study in 2015 and the GROW study in 2019. These are randomized controlled studies. They were done in early week of gestation, and the metformin was compared with a placebo. In the EMPOWER study, there was not much difference in the maternal or the neonatal outcome. However, there was decreased admission to neonatal unit in the neonate. In the GROW study, which is larger study, they have shown that there was a decreased rate of cesarean section and gestational weight gain. However, the neonatal outcomes were similar. So, other studies have also been done. As we have said, metformin has been found to reduce the inflammatory response. However, there was no effect on the rate of reduction of gestational diabetes mellitus. Now, metformin and PCOS. PCOD in pregnancy increases the risk of pregnancy-related complications. There is 3 to 4-fold increased risk of hypertension and preeclampsia, as well as and they were studied in different cohorts. So the GDM cohort, the most important is the MIG-TOFU trial, where they studied the cohort in Adelaide and in Auckland. And at 2 years, there was not much difference in the BMI and the total body fat. However, they found that neonates exposed to metformin had higher upper arm circumference, scapular skin fold, and biceps thickness. When this data was later analyzed in the MIG-TOFU, at 7 years in the Auckland cohort, there was not much difference in the BMI or the fat distribution. However, in the Adelaide cohort at 9 years of age, there was an increase in the upper arm circumference. However, there was not much difference in the BMI. The follow-up study on PCOS also showed there was an increased incidence of BMI, a higher BMI in the cohort exposed to metformin. However, the total body fat and fat was unchanged in this patient's cohort who were exposed to metformin in PCOD. Now, this was a study which was published by the group from India. It is a meta-analysis and systematic review. It was recently published in 2024. They analyzed data from 10,117 children mother pair. So they found that the rate of obesity, diabetes, or motor development issues were similar until 11 years. So their conclusion was that metformin use in pregnancy did not show any adverse effects compared with insulin on long-term outcomes in children and their mothers. And this has been widely cited in the Endocrine Society as well as in Diabetes UK, which states that metformin may be safe in mothers, and the safety that we have for us right now is up to 11 years of age. Now, there were concerns about long-term effects on reproduction because in animal studies, it has been shown that metformin exposure in utero is associated with reduced testicular size and growth. And this has been linked to impairment of reproductive health of the offspring. However, at 33 to 85 months, there was a study that was done. There was no difference noted in the testicular size of boys aged 33 to 85 months. There was between those patients who received metformin or insulin. So who could be considered for metformin based on all these evidence? If the patients are obese, we can consider them in the very obese to minimize weight gain. And there is a small evidence, but ultimately this is a personalized decision. We have to look at the data and the long-term outcomes. In PCOS, we can consider continuum, especially in those with BMI more than 30 kgs per meter square. Why? Because it has been found that those patients of PCOD who have more than 26 kg per meter square, there was a higher chance of pregnancy, and it does not reduce the infant size. In gestational diabetes mellitus, we can consider, as we have said, and type 2 diabetes mellitus.
Can you hear me?
If the patient is already on metformin, we can consider contouring. However, if there's evidence of small for gestational age in the fetus on ultrasound surveillance, we should stop. And we should consider as an adding dose in those patients who require higher doses of insulin because it is an insulin sensitizer. So what do we know about metformin in pregnancy? It is safe and effective. It is linked to less weight gain and hypertensive disorder. There's lower risk of neonatal hypoglycemia. However, there is scarcity of randomized clinical trials in GDM as well as in the other cohorts. And the efficacy of metformin is being studied mainly against insulin. We need to study it against glyburide, which is also approved. And data using CGMS is scarce. Thank you.
Thank you, Dr. Viva, for your nice presentation. And now the topic is open to the floor for any query or for any comment.
Dr. Fivator Neglect, I wanted to ask, is there any contraindications for using metformin in a pregnancy? What are the contraindications where we cannot use it?
I'm so sorry actually, but I can't hear the question.
Can you hear me? Can you hear me?
Yes, I can hear you. Yeah.
Contraindications.
Contraindications.
Yes.
Okay, the contraindications of metformin. So as we have seen, metformin can be safely given. However, there are certain cohort, like a recent study has come, the eMERGE study, and it is an analysis of those patients who are at risk for small for gestational age. As we have said, when we look at the fetal abdominal circumference, if it is less than the 10th centile, then those are the patients for whom metformin should not be given. That is one major contraindication. And in those patients who require insulin and who are already on insulin, and if they require less doses of insulin, then adding another drug for which has transplacental passage and for which we have data only till 11 years may not be an option. But still, based on all these things, we have to explain to the patients.
Okay, thank you.
So once again, thank you very much, Dr. Viva. For your nice presentation. Now I hand over to my.
The organizer, can I guess call upon Arundhati Das Gupta for the next. Dr. Arundhati Das Gupta will talk about the gestational diabetes mellitus recent updates. Dr. Arundhati is Director and Consultant Endocrinologist, Rudraksh Super Specialty Care Siliguri. And he has get so many awards. A.V. Gandhi Award 2012 Best Thesis, Diabetes Awareness Initiative Award 2018, Young Achiever Award NCCD 2022, ESI President's Appreciation Award 2022, RSSDI Innovative Award 2022, Icon of Endocrinology Award 2024, Course Coordinator for PHFI and several other national and regional training programs, presentations at several national and international platforms, several national and international publications. Now, please, Arundhati Das Gupta, please come on and give your.
Thank you so much for that kind introduction. Can you hear me?
Yes, we can hear.
And I'm sharing the slide. Please let me know if you can see the slide. Can you see the slide?
Yes, we could see. We can see.
Okay. So good afternoon. And thank you for inviting me to be a part of this program. Unfortunately, as the circumstances are, we have to do it in the hybrid mode, but nevertheless, it's a great honor to be a part of the next conference. It's more than 5.9%, not in the diabetic range, less than 6.5, 6.4, but 5.9 to 6.4. There you would go ahead with nutritional counseling. You would go with periodic testing of glucose levels weekly to identify individuals with the high glucose level. And if you see that, in spite of the nutritional counseling, the lifestyle counseling, the levels are continuously beyond the target range, then you would, you may decide to start off with treatment which can be prescribed, right? So if the fasting is predominantly more than 110, even before 18 weeks of gestation, there you might decide to go ahead with treatment, even though these people are not in the diabetic category, but they are more likely to go into the gestational diabetes later on. So which test? Now when you decide to go for the 24 to 28 weeks, suppose you tested earlier, everything was normal, you will still go for the 24 to 28 weeks. But then the question is, are you going to go for the one-step strategy or are you going to go for the two-step strategy? One-step strategy, as we know, fasting 1 hour and 2 hour, 92, 180 and 153. Two-step strategy is, it is irrelevant when the patient came, you're just giving 50 grams of glucose and you measure the blood glucose after 1 hour. If the levels are more than 130, then you go ahead with the 100 gram OGTT, where you're looking at fasting 1 hour, 2 hour and 3 hours, 95, 180, 155 and 140. So So that's how you would categorize GDM. You could decide to go ahead with any one of them. There are some countries which follow more of the one-step strategy. There are others which follow more of the two-step strategy. Now, we know that this is the data that the ADA has fallen back upon, to put ahead their guidelines. So this is one study that they have quoted, and they've said that in those people who were diagnosed to be GDM by the one-step approach, the levels who were diagnosed to be GDM were much higher. They were, but later on, what was seen that 11 years after these pregnancies, these people who were diagnosed by the one-step approach, they were threefold higher to develop pre-diabetes and type 2 diabetes. So one-step approach, this group has said that would be beneficial for the increased screening of patients for diabetes and pre-diabetes after the delivery. So based on this study and some others which have similar findings, the ADA says that the one-step criteria is the best criteria to optimize gestational outcomes, because these are the only ones which are based on pregnancy outcomes rather than the endpoints such as prediction of subsequent maternal morbidity. This is again another study which was done in 2021, and ADA has again fallen back on this for the guideline and they've said that this is a trial of testing at 24 to 28 weeks by the one-step method vis-a-vis the two-step method. And they've said that despite more individuals being diagnosed as GDM using the one-step method, there was no difference in the pregnancy and the perinatal complications. So one-step method identifies long-term risks of maternal pre-diabetes and diabetes, as well as offspring glucose tolerance. So categorically, though the ADA guidelines mentions both the tests, one-step and two-step, ADA guidelines emphasize that one-step testing is better. This is the NIH panel who however identified that the two-step approach is better. ACOG also says the two-step approach is better, but you can use either of this based on the convenience of the patient. Nowadays we're talking a lot about the CGM. So when you're talking about screening of gestational diabetes, would a prior CGM have any role to play? Now, we do not have enough data telling us. We have data with the use of CGM in type 1 diabetes now. So it is strongly recommended that type 1 diabetes patients who go on to have pregnancy, they should have a continuous glucose monitoring done. But we do not have a lot of data about the same in type 2 diabetes or GDM. So whether you're going to use a CGM in your type 2 diabetes patient and a GDM patient, ADA says that should be individualized based on a treatment plan, circumstance, preference, and needs. Now, you must remember that if you are using a continuous glucose monitoring, the glucose goal is the same as that is given in type 1 diabetes. So what would you want? You would want a TI time in range between 63 to 140. And for type 1 diabetes, the goal is more than 70%. Below range is less than 63. You'd want less than 4%, and extremely below range is less than 54, which you would want less than 1%. Above range, that is more than 140, should not be more than 25%. Very importantly, supposing you are seeing your GDM patient and you've got the CGM data and you've seen that there is hypoglycemia somewhere, you must not immediately lead to a reduction in the insulin dose or increase the carbohydrate intake. You must confirm this with the blood glucose meter measurement. It's again what the FDA has reiterated. If you look at other studies that have looked at the continuous glucose monitoring in GDM patients, they've seen that the mothers of those children who have lower gestational age, they were seen to have higher glucose overnight compared with the mothers without LGA patients. So when you're putting, obviously when you're doing an SMBG, you cannot detect these patients all the time. So if you're putting in a CGM and you're seeing that glucose levels are higher, above the targeting range, these are mothers who are more likely to have smaller for gestation or large for gestational age babies. We are having a recent study which is going on, it has not been published. This is the Go Mom study. Here what they're doing is they're using a CGM between 10 to 14 weeks of gestation and trying to understand whether patients who have higher, remember when you're looking about this criterion of 63 to 140, somebody who's got a level of 140 or 150 on a random basis, you would not have otherwise, taken it very seriously. But here when you're talking of 10 to 14 weeks of gestation, you would, even look at it very seriously and see whether this has any relationship with the subsequent gestational diabetes. When you're treating a GDM, what is the goal? There is no change in the guidelines. This time is the same. So the fasting goal remains at 70 to 95, 1 hour at 110 to 140, and 2 hour at 100 to 120. Now talking about the early GDM and the mild GDM. This is the study which came out in Lancet this year. They said that around 14% of pregnancies are affected by gestational diabetes. Of this, 30 to 70% can be diagnosed before 20 weeks of gestation. And those who develop gestational diabetes, and this is not type 2 diabetes, so early gestational diabetes is associated with worse pregnancy outcomes compared with patients with late gestational diabetes. So this study has said that it is, this analysis has said that the benefits of treating gestational diabetes from 24 to 28 weeks of gestation, they were seen better when you took better control in the early screening. Again, another paper talking about early screening and diagnosis, and this came out in the Diabetes Research in Clinical Practice. They said that the fasting glucose level modified the effect of early treatment. So early treatment meaning less than 20 weeks, you are getting a fasting level which is more, and you can see here that the target is even lower out here. And they're talking about 5.3 to 7, which is even lower. So here they're saying that a higher fasting early in pregnancy, even before the GDM is diagnosed, that has a connection with perinatal complications and should be treated immediately. This is again a very interesting study. A total of 802 women, they underwent randomization. Here OGTT was done at 15 weeks, not 24 weeks, 15 weeks. Now, and they looked for adverse neonatal outcome. Now, when they compared it, they saw that somebody who had a GDM diagnosis by the OGTT early in the 15th week, there the neonatal outcome was 24% and they were treated, and as compared to 30% in the group that was not treated. Pregnancy-related hypertension was almost similar. Neonatal lean body mass was again very similar. So if you give an OGTT before 24 weeks and you diagnose GDM and you start treatment, so are there any benefits? The benefit that they basically saw in this was that not in terms of maternal benefits, not in terms of lean body mass, but in terms of the composite adverse neonatal outcome, which was basically related to the neonatal respiratory distress. So if you're treating early, if you're diagnosing early with the OGTT and you're treating early, then there are chances that the neonatal respiratory distress will be less. Having said that, we must understand that OGTT values have not been set for this period of gestation. So we do not know whether this target or the same cutoffs can be applied in this period of gestation. This is just one study that says that probably maybe you're testing a little earlier is likely to benefit neonates later on. But then this is again just one study which has looked into it. It is not what the guidelines say. So, but this is something material for thought, because more and more, as we are progressing, more and more emphasis is being given to earlier diagnosis of gestation. So you tested maybe in the first month, and there the HbA1c was normal, the fasting TB was normal, but will you do an OGTT before 24 to 28 weeks? That is what is being debated. AD has still not asked to do the OGTT, but they have said that you have to see the fasting and the HbA1c before 15 weeks. But this kind of study, which was a very comprehensive study that puts in food for thought whether there should be a change in that. So, yeah, again, mild gestational diabetes, long-term child health, no definite benefits in this particular study. Treatment modalities, we've had a very intensive discussion about the use of metformin. Generally, AD still says the medical nutrition therapy, physical activity, and weight. Physical activity is at times restricted in pregnancy. In GDM, more and more emphasis is being given to a good and healthy lifestyle with physical activity programs, and these are studies, reviews which have told us that there are good results, the use of exercise as a need. Metformin, we know AD still does not allow metformin. They are still not saying that use metformin, even though we have data that we've seen extensive data presented by my previous speaker. But AD still says that no, though it is associated with lower risk of neonatal hypoglycemia and less maternal age gain, but treatment monotherapy failure is there. And the children later on have been seen to have heavier and higher waist to height ratio. So they are quoting these studies where they are saying that they are still not advocating the use of metformin in the use of DDM patients. And particularly there was a question some time back about the contraindication. So if there is growth restriction, as my previous speaker has said, or there is any hypertension or preeclampsia, their metformin definitely not be used is what means. This is one paper which came out this year, a comprehensive review which looked at metformin in gestational diabetes, and I have still not advocated because of the transplacental passage. Though it reduces gestational weight gain, even in hypoglycemic macrosomia, but they have said its efficacy for glycemic control has not been demonstrated. Similar study which came out again last year, they said that metformin was not superior to placebo for the composite primary outcome. Individuals with diabetes who have, they can be put on aspirin therapy for preeclampsia prevention if they have chronic hypertension, autoimmune disease, multiple moderate risk factors like obesity, age more than 35, and the other factors that have been laid down by the US Preventive Service Task Force. Telemedicine is coming up in a big way in the management of pregnant women with gestational diabetes. There's a meta-analysis where they've shown that definitely, you would be seeing your patients in person, but telemedicine can take a big load off and can also effectively bring about better control. Regarding postpartum considerations, when should they be tested after delivery? 4 to 12 weeks with a 75-gram glucose is the same thing. Earlier we used to do it 12 weeks, now it's 4 to 12 weeks. HbA1c is still not done at 4 to 12 weeks because of the impact that HbA1c could have had, the pregnancy could have had on HbA1c. And if there is continuous, unequivocal hyperglycemia, if more than fasting is more than 126 or people more than 200, then the diagnosis of diabetes is made and it has to be treated. Okay, this person also needs to be followed linearly because the chances of getting diabetes is 20% at 10 years, like 30% at 20 years, and 60% at 50 years. So they need to be treated every 1 to 3 years, even if the first results at 4 to 12 weeks of postpartum are known. So we'll not go to the details. Just take a quick look at some of the other recent updates that have been published this year. This was a study which looked at the CGM measure differences in pregnancy with or without gestational diabetes, and they say that if early in pregnancy, less than 17 weeks, you put in a CGM and the glycemic patterns are indicative of GDM, then the chance of going into GDM and adverse pregnancy outcomes are more. So this is again what I was emphasizing, that nowadays more and more emphasis is being given to the early diagnosis or early indicators of GDM. So here, as you can see, those in the early weeks, if the levels are within this.
Hello.
To one.
Madam, the time is off. Please try to sort it out.
This is another study that has been done, which has linked the gestational diabetes in terms of the intrauterine microbial exposure, and saying that the children of gestational diabetes, they have an altered immune response because of this alteration in the intrauterine microbial exposure. Another study which says that mid-pregnancy ferritin levels could be associated with postpartum glucose metabolism in patients with gestational diabetes. Another one, which is I think an important one, is again which is telling us that Mediterranean dietary pattern. If you start off with this in a person who is at a risk of going into GDM, then the chances of getting GDM or the risks associated with something that can be start off with Mediterranean dietary pattern. And the last is about testing stuff being done if the mother is GBL and the child allowed to sleep for more hours, then the chances of the child developing insulin resistance is less. That's an important I think this is what we were talking about, the sleep and insulin sensitivity. And these were the studies that I could find in the last 1 year that have been published that are looking at the gestational diabetes. I'll end with this just quote. This is about the patients, and it's about telling them that on food or changing. It's about small changes. And the treatment of gestational diabetes also. It is very similar. We do not know what is perfection when we are trying to treat gestational diabetes, but we are going about it. We are making small changes and progressing rapidly. Now that we are understanding.
Please shorten off the presentation. The time is up. Okay, Dr. Arundhati explained nicely about the recent update of gestational diabetes mellitus. So the topic is open for discussion, and then any questions from the house? Dr. Arundhati, I want to ask one question. Hello? Hello? Can you listen me? Hello? Hello?
Yes, I can hear you.
Okay.
Yes, I can hear
You can listen me now? Hello?
Yes.
Okay. You have explained nicely about the screening before 24 weeks earlier. But now there's so many guidelines are coming out, recent guidelines. At the first visit of the pregnancy, yes, so many guidelines are there. We do this DIPSI test for all a pregnant lady. So what is your opinion about that? Hello, can you listen me? Hello?
You very well because there is.
Can you listen me? So since there is a technical error, difficulty, I think we'll pass on to the next speaker.
Now we are coming to the last speaker, Dr. Ashok Krishna Bhuyan. The topic is management of diabetes during and after pregnancy. Dr. Ashok Krishna Bhuyan, sorry to say that we do not have his biodata. He is MD, DM Endocrinology. And I would like to request Dr. Ashok to deliver your talk on management of diabetes during and after pregnancy. Please start.
Thank you. At the outset, I would like to thank the next organizing committee for giving me the opportunity. So let me share my slides first. I think my slides are visible. Hello?
Yes.
Hello?
Yes.
I think my slides are visible.
Slides are visible.
Okay. So today I'll be discussing about management of diabetes during and after pregnancy. There's some issues with my laptop. I can't change my slides. Yeah, my slides are visible now? Hello? Hello?
Hello, your slides are not moving.
Okay. I'll again try to share it. Slides are coming, but it is not moving. I don't know why it is doing so. Okay. It's not moving. Sorry, my slides are not moving. Why? I don't know. Can somebody help me?
You just put it in slideshow.
I cannot, this is coming in a separate window. I cannot make it enlarge. I don't know why.
Okay, then without slide, you can just speak also. You please go to another window.
Yeah, is it now visible?
Yes, it's visible. Okay, carry on.
Okay. Let me start. Sorry for the technical difficulty. So today I am going to discuss about management of diabetes during and after pregnancy. So as discussed in the previous lectures, we know that diabetes in pregnancy are basically of two types. One is those who are pre-existing and the patient becomes pregnant in a known diabetic. It may be a pre-existing type 1 diabetes, it may be a pre-existing type 2 diabetes, and rarely some other forms of diabetes may also be there where a patient may become pregnant, like pancreatic diabetes, MODY, monogenic diabetes, etc. And one is the gestational diabetes, which was just discussed in my previous lecture. That is the diabetes diagnosed only during pregnancy in a patient who is not overtly diabetes prior to pregnancy. So the treatment options, all those looks familiar, but the treatment goal and the armamentarium may be so let us first discuss what is the rationale for treatment. Why we are so discussing about the treatment. What are the rationales? We know that a good glycemic control decreases the risk of maternal as well as fetal morbidity. What are the maternal and fetal morbidities? I will come to that. It not only decreases the maternal and fetal morbidity, but it also decreases the neonatal morbidity in the future, because we know that the neonates or which are born to diabetic mother, they are having a high chance of developing obesity, adiposity, and future risk of type 2 diabetes. So this is especially important in patients with GDM, where it has been seen that the offsprings of GDM has higher chances of developing obesity as well as type 2 diabetes. And if it is a female offspring, they have a higher chance of developing GDM in their pregnancy. Now, what are the complications of an uncontrolled diabetes mellitus in pregnancy? We know that in the mother it may lead to hypertension or preeclampsia or eclampsia. It may lead to recurrent UTI. It may lead to polyhydramnios, which leads to increased operative intervention like increased chances of cesarean delivery. And in fetus, we know that if it is a pre-existing diabetes and the fetus is exposed to the high glucose level from the very first trimester, it may lead to fetal malformations like neural tube defect, then cardiac malformations, renal malformations, etc. Although this is not applicable for GDM, because by definition GDM actually develops in the later part of pregnancy. However, GDM fetuses are having more chances of neonatal macrosomia, and once they are delivered, they are having more chances of other neonatal complications like neonatal hypoglycemia, neonatal hyperbilirubinemia, neonatal hypocalcemia, neonatal hypomagnesemia, etc. So to combat all these complications, the management of diabetes in pregnancy is very important. So while managing this diabetic, what is the glycemic target which has been given? Although we know that the HEPO study has said that no glycemic target is protective against complications, but however, different guidelines have put forward a different guidelines or different glycemic targets. Basically, it encompasses both fasting as well as 1 hour and 2 hour PP. In pregnancy and diabetes, 1 hour postprandial is a quantity which is to be given stress in some cases. So if you see the American College of Gastroenterology, they have given a target of less than 95, 1 hour PP of less than 140 and 2 hour PP of less than 120. If you see ADA, in pre-existing type 1 or type 2 diabetes, they have a lower cutoff also, like they have given a range 70 to 95 for fasting, 1 hour 110 to 140, whereas 2 hour 100 or 100 to 120. But if it is a GDM, or those patients who are not on insulin, pre-existing the diabetes who are managed on diet or metformin alone, they have not given a lower cutoff, probably because here there is no chances of hypoglycemia. But in a pre-existing type 1 and type 2 diabetes, if we target a very low blood glucose, this may lead to development of hypoglycemia also. That is why in pre-existing type 1 and type 2, especially on insulin, they have given a lower glycemic target, but in GDM or in type 1 and type 2 who are not on insulin, they have does not given a lower cutoff. Now the DIPSI, the Indian guidelines, has also given a cutoff of less than 90 and less than 120. So we can say roughly that cutoff of less than 95 or a 2 hour cutoff of less than 120 will be good enough. So apart from this glycemic target, what is the role of HbA1c? Now if it is a pre-existing diabetes, whether if in the first trimester HbA1c should be targeted or not. So some observational studies are there which has showed that if you keep a HbA1c of 6 to 6.5 in the early gestation, especially in the first trimester, the chances of adverse fetal outcomes will be less. But we should be cautious that these are observational studies. There is no randomized control trials to see these effects. So we should keep in mind that if we target a HbA1c of 6 to 6.5 in a pre-existing diabetes, especially in the first trimester, we should also be careful about the hypoglycemia when we are trying to achieve this very low target. However, in the second and third trimester, a HbA1c target of less than 6 can be good enough, which will prevent the risk of macrosemia, the preterm delivery and preeclampsia. And now, while talking about HbA1c, we should know about some of the caveats of HbA1c, that during pregnancy, there is a physiological increased turnover of red blood cells, so HbA1c may fall normally during pregnancy. If you see a normal pregnant patient, here HbA1c is somewhat on the lower side, so it may be falsely low in a patient. So only HbA1c may not give you a true reflection of the thing. Again, we should also keep in mind that HbA1c actually is a measure of integrated measure of glucose, but it does not fully capture the postprandial hypoglycemia. And in diabetic, especially in pregnancy, it is the postprandial hyperglycemia which actually drives the macrosomia. So we may meet the postprandial hyperglycemia if we target only HbA1c. So it is recommended that it should be used only as a secondary measure of glycemic outcomes after fasting PP or other glycemic targets. And if we measure HbA1c, then probably we have to monitor it more frequently, like monthly, rather than every 3 months in a normal diabetic patient. Now, what is the role of continuous glucose monitoring? There is no much data on this, but however, there was a concept trial, which was a randomized control trial of real-time continuous glucose monitoring in addition to standard care, versus standard care alone in patients with type 1 diabetes who become pregnant. They saw that use of a CGM, especially in type 1 diabetes, there is a mild improvement in HbA1c without an increased risk of hypoglycemia. That means they can reduce the time glucose fluctuation or glycemic variability, which is now gaining importance nowadays. It helps in keeping the blood glucose more within the time in range. So it will prevent the neonatal hypoglycemia and LGA birth. So this continuous glucose monitoring may be another important issue in pregnancy, where especially in type 1 diabetes who become pregnant, where there are lots of fluctuations and there may be risk of hypoglycemia also. Now with this target, how can we achieve this target? We know that there are medical nutrition therapy, then exercise. Although medical nutrition therapy can control almost up to 80% of the patients with GDM, but probably medical nutrition therapy and exercise is not enough to control existing type 1, especially type 1 and type 2 diabetes. Although MODI can be managed with medical nutrition therapy and exercise as well. So there are pharmacological therapy. Now, what should be the ideal diet during a pregnancy? You know that we have to be very cautious while calculating the calorie intake in pregnancy, because on one hand, we have to give a calorie-restricted diet so that the patient does not develop postprandial hyperglycemia, and at the same time, we have to give adequate calorie enough so that the fetal and neonatal growth is optimized. So there has to be a fine balance in the calorie intake, and we are saying that calories are not different from pregnant women without diabetes. So if pregnant women with or without diabetes, they need the same amount of calories. However, it depends on the pre-pregnancy weight, the activity of the patient, and the gestational age. So we can say that roughly during the first trimester, a patient will require 30 kilocalorie per day. If it is a normally pre-pregnant weight patient, around roughly 2000 kilocalories. Whereas if the patient is obese in prior to pregnancy, then he should cut down his calorie requirement to 25 kilocalorie per day, or roughly 1/3 or around. But again, we have to think that there should be a minimum intake of 600 kilocalorie per day. Otherwise, if you give a calorie of less than 600 kilocalorie, the patient may develop diabetic ketoacidosis, because we know that pregnancy is a ketogenic state. Now, these are the macronutrient distribution. For diet, we have to keep the carbohydrate as low as possible to prevent the postprandial hyperglycemia, roughly 35 to 45%, or we can say that 170 grams of carbohydrate per day, then 20% of protein, and rest 30 to 35% of the fat, with an adequate 28 grams of fiber per day. This amount of macronutrients can be divided into 3 small moderate sized meals and 2 to 4 snacking. In pregnancy, actually small frequent meals is a good option rather than giving 3 major meals. Then next, what are the recommended weight gain during pregnancy? This is a guideline which has been given by Institute of Nutrition and Institute of Medicine, and you can see that it again depends on the pre-pregnancy BMI. If the patient is underweight pre-pregnancy, then probably we should target a weight gain of 12.5 to 18 kg during the whole pregnancy, whereas if the patient is obese pre-pregnancy, a weight gain of 5 to 9 kilogram during pregnancy will be sufficient enough. Now, what is the role of exercise? Actually, ADA says that women without any significant medical or obstetric contraindications should be encouraged to start moderate exercises. Some contraindications may be there, like placenta previa or uncontrolled diabetes or uncontrolled hypertension, preeclampsia, proteinuria, where moderate to vigorous exercise is contraindicated, but otherwise moderate exercise is encouraged during pregnancy. Walking is the best aerobic exercise. Sometimes simple resistance exercise may be incorporated, but should not be severe enough. It should be like simple dumbbell resistant bands or pregnancy pilates. And the activity of 30 milligram per day is recommended, but it can be subdivided into 3 sessions. Probably after break, lunch they can go for 10 minutes, or after dinner they can go for 30 minutes. So these are the absolute contraindications for exercise during pregnancy. As I have already mentioned, if there is a pregnancy with hypertension, preeclampsia, things or diseases. Now, coming to pharmacological management.
Your time is over. Please shorten.
Okay. So I was given 15 minutes, no?
Yeah, 15 minutes is over with some network issue and all that.
Okay. So pharmacological management, we know that largely depends on insulin. Insulin is the first line agent recommended for treatment of GVM and also in pre-existing diabetes. So I will not go into metformin and glyburide because this has already been discussed by our previous speaker, Dr. Piva. With some caveats, metformin can be a second option if the patient is not convenient enough to take insulin or he has some hindrance to take insulin. Otherwise, insulin is the first option. Glyburide, we don't recommend it, glyburide. So still ADA does not recommend it. Insulin therapy is the best. It can be a basal bolus regimen, or sometimes in a GVM patient it can be managed by 3 times bolus insulin without a need for basal insulin, and sometimes insulin pump can be given. What is the dose of insulin in pregnancy? We start with roughly, depending on trimester, like 0.7 to 0.9 units per kg per day. But again, you can have your own protocol to start pregnancy. Intrapartum management during delivery, a glucose infusion pump is the thing which all guidelines recommend, and it should be, and during delivery or during parturition, your blood glucose target should be around 100 milligram per deciliter. It will help to prevent neonatal hypoglycemia. It will also prevent to develop ketoacidosis, especially in type 1 diabetes. Now, after follow-up after delivery, most of the insulin requirement comes down dramatically. It is because of the expulsion of the placenta. So, a pre-existing diabetic will require 50 to 80% lesser in insulin dose, whereas in DDM, all the treatments can be stopped and they should be rescreened after 6 to 12 weeks for persistence of diabetes with an oral glucose tolerance test. And management during lactation, insulin is the safest thing, although it is secreted in human milk, it is not absorbed by the infant. If the patient was already taking metformin, metformin is minimally secreted in the breast milk, so can be taken. DPP for GLP, SGLT2, no definite guidelines as of now. We don't recommend using this drug during pregnancy, during lactation. And there's always a risk of future diabetes in DDM, which tunes to a tone of 20 to 60% after 5 to 10 years of diabetes. And it depends on so many factors, like what was the pre-existing diabetes. Sometimes, not most of the diabetic actually develop type 2 diabetes in future, so we'll be very careful while monitoring these patients, and this patient require lifelong monitoring for development of future diabetes. With this, I conclude my talk. Thank you for your patient hearing.
Thank you, Dr. Ashok Krishna Buyan, for a deliberate and a nice presentation. Now the topic is open for discussion to the House. Any questions? I think since there is no questions, and then because of the time constraint, I think we'll close our session.
Thank you.
Thank you very much, all the respected presenters and our respected chairperson, ma'am. Now, before we end this session, we'd like to take a moment to honor and felicitate our respected chairpersons. To do the honor, we'd like to request Dr. Prem Chand Singh, former President, NEFS. And we'd like to request our respected chairperson, ma'am, Dr. R.K. Praneshwari Devi. Respected Dr. R.K. Praneshwari Devi, Professor, Department of Gynecology. Thank you very much. And would like to request Dr. T.H. Netajini Devi. Thank you very much for chairing the second scientific session and steering the session so effectively. Thank you so much. And moving on, next for the next session, we'd like to request our respected chairpersons on the dais. First, we have Professor Dr. T.H. Premchand Singh and Dr. P. Narendra Singh, and also we have Professor Dr. T.H. Bhimo Singh. Now I would like to hand over the mic to our respected chairpersons.
Good afternoon, everybody. Good afternoon, everybody. We are going to have the last session I'm in the session before lunch now. We have got very important topics in this session. Number one is the medical ethics by Dr. Visulata Rajkumari. And the next topic will be quality and affordability of genetic medicine available in medical ethics, Genetic Kendra by Dr. L. Nelson. Now we're going to have the first topic of this session. I would like to request Dr. Visulata Rajkumari to kindly come up to the dais and lead her topic. Medical ethics is a very important topic, especially of the number of problems arising between the Dr. Visulata Rajkumari. Is he around here? Okay. Now I'd like to request Dr. Nelson. Dr. Nelson will be talking on the quality and affordability of the generic medicine available in Jan Avasthai Kendra. It's a very interesting topic indeed. Now most of the people are asking whether they can afford, they can go for generic medicine because it's much more affordable than the medicine available in the market. Now I would like to request Dr. Nelson to kindly give his speech.
Very good afternoon to the respected chairpersons, distinguished audience, and my dear friends. Today I'll be talking about a very important flagship program of the Government of India. Although I don't want to stand between you and the lunch, everybody must be hungry as we are behind schedule. I'll just rush through what is the important points of the Jan Aushadhi program. So the Pradhan Mantri Jan Aushadhi program was launched in 2008 with the objective of making quality medicine, generic medicines available to all the citizens of India. So it was launched by the Department of Pharmaceuticals, Ministry of Chemicals and Fertilizers, as I said, in 2008. Under the scheme, dedicated outlet known as Jan Aushadhi Kendras are open to provide generic medicines at affordable prices. So the current scenario is as of October 2023, there are more than 9,000 Jan Aushadhi Kendras functional across the country. The target is to increase these kendras by 11,000 by March 2025. The product basket of the Jan Aushadhi comprises more than 1,700 drugs and 280 surgical items. The scheme is implemented by a society registered under the Society's Registration Act, that is the Pharma and Medical Bureau of India. We are sorry, there's some problem with the audio visual. Sorry for the interruption. I will just continue with the presentation. The main objective of the Jan Aushadhi is to make quality generic medicines available at affordable prices to all, especially the poor and disadvantaged sections of the society. Continuing with the aims, it is to ensure access to quality medicines, create awareness about generic medicines, and ensuring the quality of generic medicines sold under the scheme by sourcing them from WHO GMP certified manufacturers. So why this program is important in India is that there is a need for affordable and quality medicines in India because we have a very large population, there is a high burden of disease, which may be communicable or non-communicable, and many of them require long-term medications. So as we all know, there is a rising healthcare cost, and people are more aware of their health now. So affordable and quality medicines are crucial for improving the health and well-being of Indians. So some of the types of medicines available through these schemes are sold at significantly lower prices than their branded counterparts. The type of medicines available through these schemes are maybe allopathic medicines, Ayurvedic medicines, and surgical and consumables. And the quality and standard certifications of the BJP medicines are sourced from WHO, as I mentioned earlier, WHO GMP, World Health Organization, Good Manufacturing Process, certified manufacturers. The quality standards and certification process of these medicines are to follow the WHO GMP certification. And there's a stringent quality control, and approval of the drug controller is also taken. And we also need, they also have to have authorized pharmacists to dispense these medicines. As I said, these medicines are priced at an average of 50 to 90% lower than their branded counterparts. For example, a branded medicine that costs 100 per tablet may be available at Jan Aushadhi for 10 or 20 rupees per tablet. So this significant difference in pricing makes the PM-BJP medicines accessible to a larger population, especially those who cannot afford these branded medicines. And they also provide various incentives and subsidies to open such cameras all over the country. And there is a provision for a 20% margin for these dealers also. Some of the examples of, you can see enalapril in the PMJ, this scheme market price around 64 rupees, but under the PMJY it is around 8 rupees per tablet. So this is just an example. Amlodipine, most of them brands cost about 87, but it comes at 7.5 rupees under this scheme. Even for joint replacement, they are coming up with this joint replacement at 65, more around 65 to 59% lesser price than the branded. Another, if we go earlier to the next slide, see, if we talk about omeprazole, it is 462% costlier than the PMJ, this scheme capsules, the branded ones. So the role of PM-BJP in achieving the goal of universal health coverage in India, the scheme has helped in improving the availability and affordability of essential medicines, especially for the economically weaker sections of society. This has helped in reducing the financial burden of healthcare expenses on individuals and families. Thank you.
Thank you, Dr. Nielsen.
Thank you, sir.
There is, we are very much behind the schedule, more than 1 hour. So we will entertain only one question. If anybody wants to ask one question, will be entertained. If there is no more questions, thank you, Dr. Nelson.
Thank you, sir.
Yeah, please, please. Okay.
Yes, sir.
Anybody, any questions?
Good points. Listen to it. Very good topic. As a clinician, and there is some discrepancy between John Osady and the clinicians. One way is not to buy medicines. Another way for pharmaceuticals is to buy medicines. So it's a very good thing that you are encouraging. I know the theme too.
Yes.
But how far is it true that medicines should not be purchased? I think all the clinicians gathering here, if you highlight, would be happy. Thank you.
See, Tamo, this is a very pertinent question. Like, see, whether we wear Bata or Adidas or Nike is one person's choice. So if we cannot say probably we'll compete in the Olympics by wearing Khadim, no, sir? So it is up to them to decide which medicines to consume, maybe branded or then also the ones. They might be equally effective, but see, some of the Jan Aushadhi medicines, they have the technology of being enteric coated or not coated, and all those tastes or smell and all those things are also quite relevant. So I would love to like to leave it to the public to decide whether to. But I found one very interesting prescription, probably from RIMS, where the doctor has written, put a seal stamp that the patient can buy generic medicines of the same composition. It is up to them.
This is what I exactly wanted.
Thank you.
This is what, if you just identify the person also, I think would be welcome. And this is what why I exactly wanted.
Thank you.
This is a welcoming speech from your side. Thank you so much.
Thank you.
Thank you, Dr. Nelson. We just received his biodata. We will just briefly announce Dr. Nelson Loitongbam. He is at present Assistant Professor, Department of Psychiatry at Jennings. He is a former Secretary of Indian Medical Association Manipur State Branch. At present, Executive Committee member of Manipur Medical Council, and also Secretary Indian Psychiatry Society Manipur State Branch. He was in charge registrar of Manipur Medical Council before also.
Thank you.
In continuation of you have given a very nice talk. The point which we have to know is National Medical Commission on 2023 has has announced that it is a mandate to prescribe drugs only by their generic names rather than by the brand. So we have to keep this in mind and adjust according to the situation. This is what we would like to share to the audience. Thank you, Dr. Nelson.
Dr. Rajkumari now, I think. Raju Biswalata. Now she's not there. We will close the session now.
Before we end the third session, would like to honor and felicitate our respected speaker and respected chairpersons on the dais. And to do the honor, would like to request Dr. Lalan Prasad, former professor, Regional Institute of Medical Sciences, your presence on the dais, sir. First of all, would like to request our respected speaker, Dr. L. Nelson, Assistant Professor, Psychiatry Department. Okay. Yeah. Thank you very much. Now I would like to request Dr. T.H. Premchand Singh to give us a moment to honor and felicitate you with a token of appreciation. Thank you very much. And next, would like to request Dr. T.H. Bimo Singh. Thank you very much, sir, for your time. Okay. Ladies and gentlemen, now we have reached the lunch break. So lunch is being served at the first floor, I think. So we kindly request everyone to proceed and enjoy the meal prepared for you. Please note that the next session will begin promptly. So we request everyone to return to the auditorium on time. Thank you and enjoy your lunch. The lunch is being served at first and second floor.
4 साल की मेहनत,
700 से ज्यादा टेस्ट फ्लाइट्स।
लग रहा था राइट नहीं रॉन्ग ब्रदर से,
पर फाइनली प्लेन उड़ा ही दिया हमने। राइट ब्रदर?
बिल्कुल राइट ब्रदर।
तो अब वेकेशंस,
प्रेजेंटेशन,
कॉर्पोरेट चोंचले।
विश इट कुड जस्ट मेक इटसेल्फ ऐसे।
Get tailor-made presentations in seconds with Magic Design.
Sir, the bill doesn't pay itself.
Canva, दिल से डिजाइन तक।
Spices, this is your tongue to blaze hard. Damn, let me hear every one of you say, hell yeah. It's a fiery dream, hell yeah. Come on, straight to the beat now. It's the yippee fiery hot and spicy kimchi. Daibao, raise the heat with on a high key. It's the yippee fiery hot and spicy kimchi. Daibao, slap the fire like you know you like it. Let us show you what spices really like. When you twirl it and you slap it, it's a hot delight. An explosion of spices, a sensation of flavors. It's full of surprises. It's the yippee fiery hot and spicy kimchi. Daibao.
Hosea! Querido tío que todavía usa Roll-On, pásate al Steel y al Spice.
The new Dyson Airwrap ID creates defined, perfect curls that suit your unique hair type. The Dyson Air Straight dries, then creates naturally straight and shiny hair in minutes. Embrace your personal style with Dyson.
বাবা বলেছিলেন ইঞ্জিনিয়ার হ, হয়েছি। হাজবেন্ড হ, তাও হয়েছি। কিন্তু মূর্খ হয় এটা তো বলেননি। এই দেখুন, জাল পেমেন্টের SMS বলে কি বাবার থেকে নেওয়া ঋণ শোধ করছি, তারপর বলবে ভুল করে বেশি টাকা পাঠানো হয়েছে, বাবু বাকি টাকাটা ফেরত দে তো। আমি বাবার বাধ্য ছেলে, তবে মূর্খ নই। মনে রাখবেন, ইউপিআই কিন্তু সেফ, তবে কেউ এভাবে বোকা বানাতে চাইলে তাকে বলবেন আমি মূর্খ নই।
Nakin thagisu yening thalai kalin thagisu nongju thalai kapliba mawasu amana them khare now sumi sai so puna sin kon khare aigi hang la tia thamoi se nangna karam kan men sin bi dauri ba sarang la aigi om chakle thamoi se nangna karam kan them sin bi dauri ba yening tha gu nongju tha gu Sang tumuraga ayuki malang bana mikap thokan base makalam halli manglubang mangla
Nang school slagte tuition slagte and not semi when say
ai bang ning sing base tamoy na ay sang tumuraga ayuki malang bana mikap se makalam manglubang manglana magi satam manglana tai banggan ningsin base tamoy nauhali aigi mangliba manglan tamoy se nangna karam kan mikap thokan dauri ba sarang lai gi on chakle tamoy se nangna karam kan yening tha gu nongju tha gu yening tha gu nongju tha gu nauringai thamoina chamlingai nusibabu aina luna kanjaba mipai chaura wakal sina kambal chaura nusibana wakal thamoi leitada nalaihanba wakal nauringai thamoina chamlingai nusibabu ai ꯊꯋꯥꯏ ꯆꯥꯎꯔ ꯋꯥꯈꯜꯁꯤꯅ ꯈꯨꯝꯕ ꯆꯥꯎꯔ ꯅꯨꯡꯁꯤꯕꯅ ꯋꯥꯈꯜ ꯊꯃꯣꯏ ꯂꯩꯇꯥꯅ ꯂꯩꯍꯟꯕ ꯑꯩꯒꯤ ꯃꯤꯄꯥꯏ ꯆꯥꯎꯔ ꯄꯪꯂ ꯋꯥꯈꯜꯁꯦ ꯅꯪꯅ ꯀꯔꯝ ꯀꯥꯟꯅ ꯊꯦꯝꯖꯤꯟꯕꯤꯗꯧꯔꯤꯕ ꯆꯔꯥꯡꯂ ꯑꯩꯒꯤ ꯌꯣꯝꯆꯥꯛꯂ ꯊꯃꯣꯏꯁꯦ ꯅꯪꯅ ꯀꯔꯝ ꯀꯥꯟꯅ ꯏꯪꯍꯟꯗꯧꯔꯤꯕ 예능타군 농주타군 예능타군 농주타군 나겐 타기수 예능탈레이
AI is everywhere, but not all AI is equal. Smarter AI is your AI. Personalized, protected, and easy to deploy. Smarter AI brings the AI to your business and your customers. And with full stack AI hardware, software, and service solutions, we bring
Smarter AI for all.
Lenovo.
यार मैं बोलना भूल गया था पर वो दिन मैं म्यूचुअल फंड लेने के बारे में सोच रहा था। फिर क्या कंफ्यूज हो गया। सब सेम ही तो है, ये ले या वो ले क्या ही फर्क पड़ता है।
फर्क तो पड़ता है क्योंकि फर्क है, बस देखने का नजरिया बदलना होगा क्योंकि फर्क तो है।
इन्वेस्टमेंट फिलॉसफी से लेकर अटल विश्वास तक, आसान प्रोसेस से लेकर ट्रांसपेरेंट सर्विस तक, हर चीज में आप फर्क पाएंगे। बजाज फिनसर्व म्यूचुअल फंड, फर्क है। म्यूचुअल फंड निवेश बाजार के जोखिमों के अधीन है। योजना से जुड़े सभी दस्तावेजों को ध्यान से पढ़ें।
ꯅꯨꯡꯁꯤꯗꯦ ꯍꯥꯏꯅ ꯏꯐꯝꯗ ꯆꯤꯟꯕꯥꯜꯅ ꯃꯨꯛꯇ ꯍꯥꯏꯔꯝꯃꯨ ꯑꯣꯝꯆꯥꯛꯅ ꯂꯩꯍꯧꯔꯗꯕ ꯅꯪꯒꯤ ꯋꯥꯍꯩꯅ ꯈꯔ ꯐꯍꯜꯂꯅꯤ ꯑꯩꯕꯨ ꯊꯦꯝꯗꯨꯅ ꯊꯝꯂꯅꯨ ꯅꯪꯒꯤ ꯃꯤꯅꯨꯡꯁꯤꯕꯗꯨꯅ ꯋꯥꯔꯧꯕ ꯂꯩꯍꯧꯗꯅꯕ ꯑꯩꯒꯤ ꯊꯝꯃꯣꯏ ꯑꯁꯤꯗ ꯅꯨꯡꯁꯤꯗꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃꯨ ꯃꯥꯏꯊꯣꯡ ꯑꯋꯥꯕ ꯎꯠꯂꯝꯗ ꯅꯨꯡꯁꯤꯗꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃꯨ ꯃꯥꯏꯊꯣꯡ ꯑꯋꯥꯕ ꯎꯠꯂꯝꯗ ꯅꯪꯒꯤ ꯃꯤꯡ ꯄꯟꯗꯨꯅ ꯅꯨꯡꯁꯤꯕꯕꯨ ꯌꯀꯥꯏꯍꯟꯗꯨꯅ ꯊꯝꯃꯣꯏ ꯋꯥꯍꯟꯗꯅꯕ ꯅꯨꯡꯁꯤꯕꯕꯨ ꯌꯀꯥꯏꯍꯟꯗꯨꯅ ꯊꯝꯃꯣꯏ ꯋꯥꯍꯟꯗꯅꯕ ꯅꯨꯡꯁꯤꯗꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃු ꯃꯥꯏꯊꯣꯡ ꯑꯋꯥꯕ ꯎꯠꯂꯝꯗ ꯅꯨꯡꯁꯤꯗꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃු 미굽 어두다 삐키바 타모이 흔독비라무 ꯅꯨꯡꯁꯤꯕꯗꯣ ꯄꯨꯈꯤꯅꯨ ꯍꯧꯈ꯭ꯔꯕ ꯊꯧꯗꯣꯛꯀꯤ ꯋꯥꯔꯤꯁꯤꯡꯗꯣ ꯆꯥꯝꯊꯣꯛꯂꯝꯈꯣ ꯋꯥꯈꯜꯁꯤꯗꯩ ꯅꯤꯡꯁꯤꯡꯗꯅꯕ ꯅꯨꯡꯁꯤꯕꯗꯣ ꯀꯥꯎꯍꯜꯂꯝꯃꯨ ꯅꯨꯡꯁꯤꯗꯦ ꯍꯥꯏꯅ ꯏꯐꯝꯗ ꯆꯤꯟꯕꯥꯜꯅ ꯃꯨꯛꯇ ꯍꯥꯏꯔꯝꯃꯨ ꯑꯣꯝꯆꯥꯛꯅ ꯂꯩꯍꯧꯔꯗꯕ ꯅꯪꯒꯤ ꯋꯥꯍꯩꯅ ꯈꯔ ꯐꯍꯜꯂꯅꯨ ꯑꯩꯕꯨ ꯊꯦꯝꯗꯨꯅ ꯊꯝꯗꯅꯨ ꯅꯪꯒꯤ ꯅꯨꯡꯁꯤ ꯑꯗꯨꯅ ꯋꯥꯔꯧꯕ ꯂꯩꯍꯧꯗꯅꯕ ꯑꯩꯒꯤ ꯊꯝꯃꯣꯏ ꯑꯁꯤꯗ ꯅꯨꯡꯁꯤꯔꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃꯨ ꯃꯥꯏꯊꯣꯡꯅ ꯋꯥꯕ ꯎꯠꯂꯝꯕ ꯅꯨꯡꯁꯤꯔꯦ ꯁꯦꯡꯅ ꯍꯥꯏꯔꯝꯃꯨ ꯃꯥꯏꯊꯣꯡꯅ ꯋꯥꯕ ꯎꯠꯂꯝꯗ
ꯂꯩꯔꯝꯕꯅ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯊꯃꯣꯏ ꯄꯥꯜꯂꯝꯕꯅꯤ ꯅꯨꯡꯁꯤꯕ ꯂꯩꯔꯝꯕꯅꯤ
ꯂꯩꯔꯝꯕꯅ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯊꯃꯣꯏ ꯄꯥꯜꯂꯝꯕꯅꯤ ꯅꯨꯡꯁꯤꯕ ꯂꯩꯔꯝꯕꯅꯤ
ꯄꯥꯛꯆꯥꯎꯔꯕ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯑꯩꯒꯤ ꯅꯨꯡꯁꯤꯕꯒꯤ ꯍꯧꯔꯛꯐꯝ ꯅꯪꯇꯅꯤ
ꯄꯥꯛꯆꯥꯎꯔꯕ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯑꯩꯒꯤ ꯅꯨꯡꯁꯤꯕꯒꯤ ꯍꯧꯔꯛꯐꯝ ꯅꯪꯇꯅꯦ ꯅꯪꯇꯅꯦ
ꯍꯧꯔꯛꯂꯤꯕ ꯊꯥꯖꯕ ꯑꯩꯒꯤ ꯊꯃꯣꯏꯗ ꯂꯦꯡꯗꯅ ꯀꯥꯏꯍꯟꯗꯅ ꯊꯝꯕꯤꯌꯨꯀꯣ
ꯊꯥꯖꯅꯕ ꯑꯅꯤꯒꯤ ꯃꯔꯤ ꯑꯁꯦ ꯃꯥꯂꯦꯝꯁꯤꯡꯅ ꯀꯥꯏꯍꯟꯕ ꯉꯝꯂꯣꯏꯌꯦ
ꯊꯃꯣꯏꯅꯨꯡꯗ ꯆꯦꯠꯅ ꯊꯝꯕꯤꯌꯨꯀꯣ ꯀꯩꯗꯧꯅꯨꯡꯗ ꯂꯥꯞꯊꯣꯛꯀꯦ ꯈꯟꯕꯤꯒꯅꯨꯀꯣ
ꯊꯃꯣꯏꯅꯨꯡꯗ ꯇꯥꯈ꯭ꯔꯕ ꯃꯃꯤ ꯑꯁꯦ ꯀꯅꯥꯅꯁꯨ ꯂꯥꯞꯊꯣꯛꯍꯟꯕ ꯉꯝꯂꯣꯏꯌꯦ ꯉꯝꯂꯣꯏꯌꯦ
ꯇꯥꯡꯂꯕ ꯄꯨꯟꯁꯤ ꯑꯁꯤꯗ ꯑꯃꯨꯛꯇꯪ ꯐꯪꯖꯕ ꯅꯨꯡꯁꯤꯕꯅꯤ
ꯋꯥꯈꯜꯕꯨ ꯂꯩꯇꯥꯍꯜꯂꯤꯕ ꯇꯥꯡꯅ ꯐꯪꯖꯕ ꯅꯨꯡꯁꯤꯕꯅꯦ
ꯑꯄꯥꯝꯕ ꯀꯌꯥ ꯂꯥꯛꯂꯕꯁꯨ ꯅꯨꯡꯁꯤꯕꯅ ꯑꯊꯣꯏꯕꯅꯤ ꯀꯥꯎꯕꯤꯒꯅꯨꯀꯣ
ꯑꯄꯥꯝꯕꯗꯤ ꯉꯥꯏꯍꯥꯛꯀꯤ ꯃꯤꯠꯇꯪꯅꯦ ꯅꯨꯡꯁꯤꯕꯗꯤ ꯊꯃꯣꯏꯒꯤ ꯑꯔꯦꯞꯄꯅꯦ ꯑꯔꯦꯞꯄꯅꯦ
ꯂꯩꯔꯝꯕꯅ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯊꯃꯣꯏ ꯄꯥꯜꯂꯝꯕꯅꯤ ꯅꯨꯡꯁꯤꯕ ꯂꯩꯔꯝꯕꯅꯤ
ꯂꯩꯔꯝꯕꯅ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯊꯃꯣꯏ ꯄꯥꯜꯂꯝꯕꯅꯤ ꯅꯨꯡꯁꯤꯕ ꯂꯩꯔꯝꯕꯅꯤ
ꯄꯥꯛꯆꯥꯎꯔꯕ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯑꯩꯒꯤ ꯅꯨꯡꯁꯤꯕꯒꯤ ꯍꯧꯔꯛꯐꯝ ꯅꯪꯇꯅꯤ
ꯄꯥꯛꯆꯥꯎꯔꯕ ꯃꯥꯂꯦꯝ ꯑꯁꯤꯗ ꯑꯩꯒꯤ ꯅꯨꯡꯁꯤꯕꯒꯤ ꯍꯧꯔꯛꯐꯝ ꯅꯪꯇꯅꯦ ꯅꯪꯇꯅꯦ su late no su tai sel su pai de ahau badi chaningi mi su phate lai su lai de tin lai muki ringai ahin sida angang kapli su saure malem su mole satna bi su soire le tong ba da le thole wai ku pu bina do lai tong bi ki wa bi re ya hind angang kapli se ya hala jin re atya su saure malem su mole satna bi su soire le tong ba da le thole wai ku pu bina do lai tong bi ki wa bi re ya hind angang kapli se ya hala jin re mai sulate no sutai sel supai de ahau badi chaningi mi supate lai sulai de tin lai muki ringai ahin sida angang kapli kira di chat pangam loi lambi se wara di marup leira roi tai bang se khangna khanghan birem mapok se lukop da len thadarak le ahin sida ayo ayo hai rurari na ra boi ning khragani tai bang sina amai sula no sutai sel supai de ahau badi chaningi mi supate lai sulai de tin lai muki ringai ahin sida angang kapli
Querido tío que todavía usas Roll-On, ¿por qué malgastar tu tiempo bailando flamenco esperando a que tus axilas se sequen? Pásate al stick de All Spice. Esta Navidad, el auténtico premio lo canto yo y no mi axila, y solo por usar esto. Sí, acabo de entrar en el salón de tu casa y no he necesitado chimenea.
Fruit and nut, roast almond, and crackle. 3 more reasons to enjoy your favorite Cadbury Dairy Milk. Now in a fresh new look. Try all 3.
Thank you. With the permission of Chairperson, shall I start?
Yeah, please do. Please do.
Okay, thank you. So it will be, my topic will be hover around for the next 15 minutes in the advances in the insulin delivery system. Just a minute, right, sir. Allow me to control. I am unable to move my slides. Tech team, request tech team to allow me. Control is not with me. I am unable to change my slides. Is there anything to talk from there? Okay. It's visible now? Hello.
Yes, it's visible. It's
moving?
Yeah.
Okay.
Please carry on.
So, we all know the prevalence of diabetes is increasing, and there are barriers for individuals to initiate and adhere to the insulin therapy. Because it interferes with daily activity, there is a financial constraint, there will be complex reasons, injection discomfort, conflict, embarrassment. To address all the challenges and to prevent the diabetes-related complications which you are worried about, advanced and effective technology for the insulin delivery are very much necessary. What we have, if we talk about the novel insulin delivery approaches, we have oral insulin delivery, we have rectal insulin, we have transdermal insulin delivery, and we can have an inhaled insulin delivery. To see the overview methods of insulin delivery, here advantage in this slide shows this. Over the year, insulin delivery devices has evolved from the syringes to pens, pumps, and hybrid closed-loop system. The modern devices offer improved insulin delivery with minimal or non-invasiveness, which positively impacts patients' perception and quality of life. So we have used to have vials and syringes, then insulin pen. Now we have insulin pumps also. There are talk of the intraperitoneal inhaled insulin, which was approved by CDSCO in India on 12th of this month. Then we have oral insulin, buccal insulin, nasal insulin, and the transdermal insulin. If we talk about the oral insulin delivery, these are the microparticles or microspheres. Then we have a nanoparticles, we have a hydrogels, and we have liposomes. These are the things which we have in our armamentarium in the delivery system. If we talk about the buccal insulin delivery, it has gained profound attention as a potential non-invasive method for insulin administration, offering an alternative to traditional subcutaneous injection which we are using nowadays. In this technique, the absorption of the insulin occurs through the buccal mucosa, thereby they bypass the GI tract and avoids the fast metabolism, resulting in the rapid systemic absorption and potentially improved patient compliance. We have also intestinal insulin delivery. It has also gained profound attention as a potential non-invasive method for insulin administration, and it offers an alternative to the traditional subcutaneous injection. Advantage of intestinal insulin delivery system are provide a non-invasive route that improves patient acceptance and compliance, because majority of the patients are worried about the injections. There is a fear psychosis. This offers the potential to bypass the liver, results in enhancing insulin viability and more stable systemic insulin level. It also allows to potentially to mimic the physiological insulin secretion pattern, leading to the improved glycemic control, and hence results in the potential advantage in terms of convenience and the patient compliance. If we talk about the rectal insulin delivery, this method involves the absorption of insulin by the rectal mucosa. Advantage again, it is a non-invasive, more acceptable to the patient, mainly for those who are unable to self-administer the subcutaneous injection. Due to the delivery location, this formulation again bypasses the first pass metabolism, which results in the greater bioavailability and the better insulin levels. There are advances in the transdermal insulin deliveries. Transdermal and nanoparticle-based microbial patches are there, are in the pipeline. The study was published in the Advanced Delivery 2019 by Zhang et al. Now, if we talk about the inhaled insulin delivery, there are various recent studies of this inhaled insulin to deliver insulin by the pulmonary pathway. The different types of insulin inhaled devices are created mainly based on the various aerosol principles and the formulation of inhaled insulin like liquid and liposide powder insulin. Recent studies showed that dry powder insulin shows a bioavailability of near about 10%, whereas the weight aerosol shows near about 46%. But majority of this insulin gets destroyed. Started working in 12 minutes of inhalation, which is a breakthrough. I think we have still to use. It has been just approved, not given in the market, but they have given a marketing right for the inhaled insulin, which will be beneficial to our patients, and the inertia of the patient and doctor's level will go away. These were the days where we used insulin while saving. Which offers advantage over the traditional subcutaneous injection, including a non-invasive, and which in turn also potentially bypass the liver for better insulin bioavailability at stable levels, and its ability, as it bypass the liver, its ability to mimic physiological insulin secretion. The buccal insulin delivery system again has a greater potential to deliver insulin via the non-invasive approach. Closed-loop systems are enabling more people of type 1 diabetes to reach recommended glucose target. The rectal insulin delivery system again carries a great potential to be an alternative approach to the insulin administration, which offers again a various advantages like the better viability, non-invasiveness, greater patient compliance. But in this area, still more research is required to deal with various challenges and establish its clinical utility. Future directions in nanomedicine will focus on the creating next generation nanocarriers with precise targeting, real-time monitoring, and stimulus responsive features to optimize diabetes management in our type 2 diabetes as well as type 1 diabetes patient, their outcome and the patient safety. Thank you very much regarding this. Any suggestions and
Thank you very much, Dr. Dinesh, for your enlightening talk. With this, we will not take any more questions. I would like to invite another speaker on the remission or reversal of type 2 DM. Dr. Bayana Konsam, please. Dr. Bayana? We won't take questions. Thank you, Dr. Dinesh. We'll move ahead with the next speaker. Dr. Dinesh, can you hear me? I can see you on the line.
Hello.
Hello. We are not taking any more questions. Hello. Thank you very much for Thank you very much for the excellent talk.
Thank you. Thanks a lot.
Good afternoon. Good afternoon, respected faculties and chairperson, for giving me the opportunity to present this. So to start my topic, I would like to say that my topic will be the remission of the type 2 diabetes mellitus. So the agenda of my today's presentation will be the paradigm shift and a definition, the method to achieve remission, the factors favoring remission, and the summary. So the paradigm shift and the definition. So American Diabetic Society states that the mission is to prevent and cure diabetes and to improve the life of all the people affected by diabetes. So what is the paradigm shift? At the earliest 1995, we have seen that a patient with who had diabetes, when he underwent bariatric surgery, he had remission of diabetes. From that part itself, the remission of the diabetes has always been on the line. So what is a changing paradigm of the type 2 diabetes mellitus definition? So inevitably, progressive, requiring increasing numbers of oral hypoglycemic agent and eventually the insulin. This was the definition which we have been following till now. But it is the latest one is that potentially this is a reversible metabolic state precipitated by the single cause of chronic excess intra-organ fat. So the definition, the initial definition is it's out already. So the American Diabetic Association has defined at the earliest in the 2009 guideline, they have mentioned that the partial remission is the HbA1c below 6.5% with a fasting blood glucose of between 100 to 125 or sustained over at least a year without any diabetic medication. So the complete remission they have defined as an HbA1c of less than 6% and a fasting blood glucose of below 100. So they have sustained over a year without any diabetic medication. So the prolonged remission was defined as the complete remission of at least 5 years for duration without any diabetic medication. But the latest definition which has been given in 2021 is that remission should be defined as a return of HbA1c to less than 6.5% that occurs spontaneously or following an intervention and that persists for at least 3 months in the absence of usual glucose-lowering pharmacotherapy. So why remission? Why aren't we using other terms like cure? So it was derived from the oncology, where the disappearance of the signs and symptoms were there, but the relapse can always happen if there is no follow-up. So the method to achieve the remission. Before going into what are the methods, I would like to highlight that at the time of the diagnosis of the diabetes, we all know that the beta cell failure is already 50%. And the loss, is it a loss or is it a dysfunction? Everyone has mentioned that maybe the reduced number of beta cell, that is a loss. It can be either dysfunction also, or it can be de-differentiation, or which can lead to the compromised identity of the beta cell. So let's go into the pathogenesis of type 2 diabetes. It's tracing the reverse route from cure to cause. So initially the driving force of all the diabetes is the calorie excess and the muscle insulin resistance, which lead to the organ which mainly affect is the liver and the pancreas. And first it will lead to the excess glucose, which lead to the increase in the liver fat, and eventually leading to the resistance to the insulin action. And there will be compensatory increase in insulin secretion, which eventually lead to the increased liver fat, which complete the cycle of the liver. This again lead to the increase in the VLDL and the triglyceride level, which eventually lead to the increased triglyceride level in the islet cells of the pancreas. So this finally causes the increased insulin response to the glucose, decreased insulin response to the glucose, ultimately leading to the excess glucose, which complete the cycle, which is this is also known as the Taylor twin cycle theory. So coming to the first method of remission, it was described as earlier was the bariatric surgery. So we all know that there are different types of bariatric surgery which can be restrictive, malabsorptive, or both. I wouldn't be going into the details of all the type of bariatric surgery. So we can see that the different types of surgery has different target weight loss, with a maximum with the biliopancreatic diversion with the duodenal shift, which around 35 to 45% of the weight loss is there. So what is the indication of bariatric surgery in India, which the guideline is a little different from the guideline outside India. Here they should consider a treatment option for acceptable Indian which has a BMI of 35% with or without the presence of any obesity-related comorbidity, or can be considered with a BMI of more than 30 or equal to 30 in the presence of any obesity-related complication, or it can be either considered in a non-primary treatment option for the Indians which has a BMI of more than or equal to 27.5% with the uncontrolled blood glucose despite optimal medical treatment. So it should be considered as a treatment option for acceptable Indians with a central obesity with a waist circumference of more than 90 or equal to in male and more than or equal to 80 in females. So what was this was from a study which was a meta-analysis where we can see that the diabetic remission was as high as was 85% with the bariatric surgery. So what is the potential pitfall of the bariatric surgery? Either it can be mortality or the chances of resurgery is high, and other complications do happen like thromboembolism, the anastomotic leak, and severe vomitings, infection, impaired bowel healing, and can cause to even the relapse of the type 2 diabetes also. So the another mode of the going into remission is the lifestyle. For a lifestyle, I would like to define the various low-calorie diet, diet. So first is the very low-calorie diet, which is the carbohydrate content to be around 20 to 50 gram, with the carbohydrate total carbohydrate of the daily dose will be 6 to 10%. And the low-carb diet is less than 130 gram with a total of less than 26 gram. Moderate carbohydrate diet is 132 to 25 gram with the total of the RDA of 26 to 45%. With high carbohydrate diet is more than 225 gram with a total of more than 45 gram. So in this study, we can see that the various diet program, the remission rate were, with a diet program of only the total diet replacement, the remission rate were 54%. With the diet program with the meal replacement, it was 11%. With the Mediterranean diet, it was 15%. With a very low calorie carbohydrate ketogenic diet, it was 20%. So this was a study from India where they have seen the effect of the low-calorie diet on restoration of the normal glycemia in obese patients with type 2 diabetes. The problem with the Indian diet is that we have a two-measure meal, which is like high carb diet. And in this study, they have done a meal replacement with 1,059 calories per day. In this study, they have seen that responder were 50%, with the blood HbA1c decrease was found in 31%, with the weight reduction in 8%. And with, what is the pitfall of this lifestyle modification? In the direct trial, it was shown that the dropout rate were very high. That was the only issue with this mode of the remission, mode of the testing remission. So another is the pharmacotherapy. So in earlier, we have seen that with the intensive insulin therapy, we have seen that the diabetic remission was seen. So intensive insulin therapy for even for 2 to 3 weeks also can cause a glycemic remission. So it improves the islet function, induce the remission in about 46% of the patient at 12 months and 42% at 24 months. So what was the mechanism in this kind of patient where insulin was given? The effect was not just weight loss dependent, because we all know that insulin causes weight gain. And then they were not administered with a very low calorie diet or any low calorie diet. So the beta cell redifferentiation due to the relief of the glucotoxicity was considered an important mechanism for the treatment effect. This means that beta cell can come back to the normal, unlike we believe earlier, where we think that once the beta cell has been destroyed, it's destroyed completely. So what are the agents for the remission? First is, what should be the ideal medication which can cause remission? One is a rapid reduction in the hyperglycemia without causing any hypoglycemia, and it should have a rapid and a sustained weight loss. So what are the examples of the glucose lowering agent which has been tried for the remission? First is the bigonide, metformin, thiazolidinedione, pioglitazone, and the alpha-glucosidase inhibitors like miglitol, voglivose, and carbose, and SGLT2 inhibitors like empagliflozin and like others like dapagliflozin. And I'll be focusing on the GLP-1 analog, which is the latest drug medication which has been tried for the weight loss as well as the remission of the diabetes, which is liraglutide, semaglutide, and other newer molecule I'll be describing in the subsequent slide. So let's go into the GLP-1 analog. It is a glucagon-like peptide-1 analog, which is an incretin secreted by the gut hormone in response to the glucose. So in a study, we have seen that when compared with the liraglutide, semaglutide, and the tirzepatide, which is a incretin, which have effect on both the GIP and the GLP-1, we have seen that the change in the body weight was, with 3 milligram of liraglutide, it was 6.4 decrease in the weight, and for the semaglutide, it was 9.6, around 10% of the weight loss were there, and for tirzepatide, it was 9.5%. In this same study, they have seen that the reduction in HbA1c was 1.3%. With liraglutide, with semaglutide, it was 1.5%, and with tirzepatide, it was a maximum, which was 2.07%. So what are the newer anti-obesity medication which has been tried for the remission of the diabetes? First, I'll describe the tirzepatide. Tirzepatide is a newer molecule, which is a twin incretin. It is a both GIP and a GLP-1 agonist, and with this medication, it is seen that 20.9% of weight loss were present with 50 milligram weekly dose at 72 weeks. And another new molecule is the retatrutide, which is a triple hormone receptor agonist, which is act on a GLP-1, GIP, and a glucagon, and the weight loss was 24.3% with a weekly dose of 12 milligram at 48 weeks. Another molecule is oral semaglutide, which is available currently in India. And with this 550 milligram, we have seen that 15% weight loss were there. With another new molecule, orforglipron, that it is non-peptide oral GLP-1 analog, the weight loss seen was 12.4%. at 36 weeks. This is a study conducted from PZI, which has been recently published. They have tried, it's a randomized trial where they compared with the patient receiving oral medication with the usual conventional treatment. They have seen that the remission rate in the trial group patient who were receiving the oral semaglutide, there were 100% remission, and where 48% were there in the conventional group after 3 months of medication. So what are the predictors of remission? So longer the duration of the diabetes, the lesser the chance to go into the remission. So the duration should be less. And various studies have shown that less than 6 years of duration is likely to go into remission with treatment. So what are the factors influencing remission? So we can see that the higher the HbA1c, the unlikely to go into remissions, and with the duration, longer the duration, very unlikely to go into remission, and the more the number of diabetic medication or the patient requiring insulin, they are very unlikely to go into remission. And the older age is good for remission, and the more the weight loss, the higher the chances of going into remission, and the type of this bariatric surgery which you conducted to the patient. So in the direct trial, they have also seen that increased triglyceride level and even the GGT level, which is a marker of the liver enzyme, they have shown to increase the less chances of going into the remission. And another is a patient, if it's on anti-depression medication, they are very unlikely to go into remission. So to summarize my study, So weight loss, various weight loss leads to the improved health outcome. So 0 to 5%, they can lead to the improvement in the hypertension, hyperglycemia. With the 5 to 10% of the weight loss, there can be prevention of the type 2 diabetes. So for preventing, the weight loss should be around 5 to 10%. So it can lead to improvement of the fatty liver, PCOD, dyslipidemia. With 10 to 15% of weight loss, there will be various advantages over the cardiovascular system or urinary stress incontinence, NASH, sleep apnea, GERD. And with more than 50%, there is the chances of diabetic remission is there. So the weight loss important is 5 to 10% for the prevention of diabetes, with more than 15% weight loss for the type 2 diabetic remission. So this is my final slide. To reverse the cycle of the diseases, what we can do is a various options. That is, one is bariatric surgery, one is a lifestyle modification, and one is a pharmacotherapy, which can lead to the remission of diabetes. This is to conclude my study. Thank you so much, and thank you for the opportunity.
Thank you, Dr. Bayana. May I ask for your forbearance, please? We will continue with the scientific session. We'll take a break for the inaugural session now. We will take questions. Dr. Bayana, please don't leave. I mean, you can leave the stage now for the inaugural function. Be seated over there.
Okay,
we'll take the question, and we'll continue with the session after the inaugural session is over. Thank you very much. Thank you all.
Thank you so much.
A very good afternoon, one and all. Bumda magpu amugtangahana taramnog cheri ikognona kurumjeri. It is with great joy and privilege that we welcome you to the inaugural function of the 29th Annual Conference of the Northeastern Diabetes Society, NETSCON 2024, held here in the historic and vibrant city of Imphal at the prestigious Jawaharlal Nehru Institute of Medical Sciences Auditorium, Porompat. Today, as we gather under the theme Diabetes and Well-Being, we initiate a journey of learning, collaboration, and innovation to address one of the most pressing health challenges of our time. This gathering of brilliant minds and passionate hearts is a reflection of our collective commitment to advancing diabetes care and promoting holistic well-being in the Northeast region and beyond. Ladies and gentlemen, we are deeply honored to have with us an esteemed panel of dignitaries who have graced this occasion with their presence. First, we have our respected Chief Guest, Dr. Chambo Gonmei, Director, Medical Directorate, Government of Manipur, a leader whose dedication to healthcare and community welfare inspires us all. Our guests of honor, Professor Dr. G. Sunil Kumar Sharma, Director, RIMS Lamphilpat, a beacon of excellence in medical education and research. Dr. Longjam Usharani Devi, Director, JNIMS Porompat, a visionary who leads with compassion and commitment. And she is unable to be with us today due to some health issue. And she deeply regrets her absence and extends her heartfelt apologies to everyone present. Joining them on the presidium are Dr. Y. Iboton Singh, Organizing Chairman, NETSCON 2024, whose guidance and leadership have been instrumental in bringing this conference to life. Dr. K.S. Lokeshwar Singh, Organizing Chairperson of the Reception Committee, whose meticulous planning has ensured this event's success. Dr. Ketrimayum Achoba Singh, Organizing Secretary, NETSCON 2024, whose tireless efforts have made this conference a reality. So let us extend our warmest welcome and deepest gratitude to our distinguished dignitaries with a big round of applause. We'd like to have your presence on the dais.
Sir, please come, sir. Please.
And also would like to request Dr. Salam Ranabi, Treasurer, NETSCON 2024, Imphal. Ikai Kumajariba, Mitunglena, Dice Linkshin Bikraba Matunga City. Isagi chillaba matam kaitok piduna ngasi thoramasi mapung phahan bidaba yade sarugya daba yade haiduna lingbirak pagi damakta ikai khumnaba ucha boina ahan bada langjariba kudol pot kudol tamjabagi tanja du luxury. So to do the honor of felicitating our respected dignitaries on the dais, would like to request Associate Professor Reams, DM Endocrinology, Dr. L. Chief guest of today's function, Director, Medical Directorate, Government of Manipur, Dr. Chambo Gonmei. Dr. Y. Treasurer, NETSCON 2024, Imphal. We welcome you, sir. Thank you so much. Thank you so much, Dr. Romesh and Dr. Bayana, for doing the honor. And to formally welcome this August gathering, it is my honor to invite Dr. K.A. Lokeshwar, Chairman, Reception Committee.
Very good afternoon. I am honored to deliver or to present the welcome address to the August gathering of today's function. Northeast Diabetic Society, NET, its 29th annual conference of the conference, or NETSCON 2024 in Jennings. First, I would like to give my due regards and respect to the chief guest of today's function, Dr. Chambo Golmai, Director, Medical Directorate, Government of Manipur for his kind presence here and gracing this solemn occasion of academic bonanza. Next, I would like to give respect and a welcome Dr. G. A. Sunil Kumar Sharma, Director, RIMS, Lamphelpat, for his kind presence here and who is gracing this function as an academician. In absentia, I would like to welcome Dr. Longjam Usarani Devi, guest of honor of today's function, who has given her message that she was willing and physically unable to attend it because of certain physical problems. Next, I would like to welcome Sir Dr. Y. Boton Singh, Organizing Chairman, NESCON 2024 Impal, to be the guest of honor. Next, on the dais, Organizing Secretary Dr. K.C. Chachoba Singh and the Treasurer Dr. Salam Ranbir Singh on the dais. And of the dais, the many distinguished professors and teachers of yesteryears and who are still being teachers of all the young medical graduates of the state and outside the state. And all the delegates, PGs and media personnel and all the fraternity who are dedicated for this academic function. Truly it is a fact that diabetes is hovering in our society, and everybody knows in this hall that is becoming one of the greatest killer or helper to kill the individuals in the near future. As we have conquered in many diseases which has been infective or non-infective. But one of the most important disease, non-communicable disease, diabetes is still leading one of these. Many papers have been presented even in today's seminar also that it poses one of the most dangerous hurdle in our life. And all the delegates who are present here would be delighted or would be enriched in their knowledge of managing and the knowledge of the prevalence, occurrence, and steps to remediate or reduce the morbidities in our society. I think this conference should give this opinion in the society in the larger section. Last of all, I welcome all to be here till tomorrow so that the function or the academic session goes smoothly and it works with all its activities and wishes to give the message. Last but not the least, I welcome all the members of the pharmaceuticals who have dedicated and who has given keen support in organizing this particular NESCON 2024 in this auditorium of Jennings. Thank you.
Thank you very much, respected Dr. K.S. Lokeshwar, Chairman, Reception Committee, and also the Medical Superintendent, Jennings Hospital, for that very warm and inspiring welcome speech. Thank you so much, sir. Now I would like to request our respected respected Treasurer, Dr. Salam Ranbir, to deliver the keynote address of today's function.
Good afternoon, respected dignitaries on the dais. Dr. Chambo Gonmai, Director, Medical Directorate, Government of Manipur. Guest of honor, Dr. G. Sunil Kumar Sharma, Director of RIMS. And Professor Iboton, Organizing Chairman. Dr. K. Lokeshwar Singh, Organizing Reception Committee Chairperson. And Dr. Chachoba Singh, Organizing Secretary. And all my teachers and seniors and friends in the hall. We are organizing this conference because diabetes, as highlighted by Professor Lokesar, is a menace to the society as of now, because the latest data from the government of India is that around 10 crore people in India are suffering from diabetes. And the figure from ICMR published in 2023 for Manipur prevalence is around 6%, but in the morning I heard from the nodal officer of the non-communicable disease, Manipur state government, that the prevalence in Manipur is around 15%, much higher than the national prevalence which is published by the ICMR. So it is not just a sheer number of the patients which we are supposed to deal with, but is the complications with which the patients die. Because we all know that type 2 diabetes is the leading cause of end-stage kidney disease around the globe. Around 20 to 40% of patients with diabetes end up with diabetic kidney disease, and around 60% of the patients with renal failure across the globe is because of diabetes mellitus. Diabetes is the commonest cause of blindness in people between the age of 25 to 70 years, and next to accident or trauma. And we have got neuropathy, we have got heart disease, like particularly heart attack, which the prevalence of which is increased by 2 to 4-fold among patients with diabetes, and the risk of mortality, that is dying, is 2 times higher among diabetic patients who suffered from an heart attack compared to a non-diabetic. So it is just not a sheer number of patients, because if it is just a sheer number of patients, gastritis will be much more commoner than diabetes, but nobody dies of gastritis. That's why we need not give that much importance. Though it is important, patient can develop GI bleed and die, but the chance of patient dying from a peptic ulcer is very, very low compared to a patient, and the quality of life which a patient of diabetes has to undergo is horrible, because they will develop all the complications, very frequent blood testing, the carbohydrate counting before the meals, because they can't enjoy whatever food other people are enjoying. So they've got a restrictive lifestyle, though it can be modified. If they learn how to do that, they can enjoy most of the things, but still it is a bit restrictive compared to other people who doesn't suffer from diabetes. And problem is in India, if we talk about the hardcore people who are trained, like endocrinologists, there are less than 1,000 endocrinologists trained in the country. And there are many MD medicine who are keenly interested in management of diabetes, who are trained also. But if you take the number of people who are interested and keenly well trained in the field of diabetes, it's very less compared to the 10 crore population who are suffering. So it's a responsibility for all the doctors to treat the patients of diabetes, to manage them, because even if I remember one study from US, in the best center from US, if I remember correctly, that in the center, only around 25% of the patients in that medical college, is one of the biggest medical colleges in US, only 25% of the patients are managed by endocrinologists, rest are managed by the primary care physicians and MD medicine in the most developed country of the world also. So everyone has to take responsibility. That's why we are organizing this conference, so that we can impart knowledge to everyone, and so that people take interest in the management of diabetes. And even as an endocrinologist, it's not possible for me to keep pace with the recent advances that is going on, because every month there are 15 to 20 journals published in diabetes, and it's not possible for me to read everything also. So if I attend a conference, someone who has read about it will tell something about it, I'll learn something from them. So it's that we should exchange the knowledge, and then it is ultimately beneficial for our patients, so that they lead a healthy life. There are people who lead a very healthy life in spite of diabetes. With the modern therapy, with the modern gadgets, there are people who are surviving more than 50 years with diabetes. Right now, I won't name the player, but there is an international lawn tennis player. His ranking is around number 4 or 5 in world ranking. He's type 1 diabetes, but international ranking 4 to 5. There is a professional boxer in UK, type 1 diabetes, still fighting as a professional boxer in spite of type 1 diabetes. One footballer from Spain recently retired. He was in the Spanish national team in spite of being type 1 diabetes. So diabetes doesn't mean death sentence. If we manage properly, if we give time to them, if they come to us regularly, then they can lead a healthy life. Thank you, everyone.
Thank you very much, Dr. Salam Ranabi, for your valuable thoughts and insightful keynote address. Thank you so much. Now, to mark the auspicious beginning of this significant event, may I request our respected chief guest, guest of honor and president member to kindly come forward for the lighting of the ceremonial lamp. Thank you, esteemed dignitaries. With this symbolic gesture, we illuminate the path to a fruitful and meaningful conference ahead. Now, in continuation, may I request our respected guest of honor, Director RIMS, Lamphilpaat, Dr. G. Sunil Kumar Sharma, to address the gathering.
Thank you. A very good afternoon to all. Sabka namaskar. मैं आम्बू खुरमजरी. Respected dignitaries on the dais, Dr. Chambo Golmai, Director Medical Directorate, Government of Manipur, Dr. Y. Iboton Singh, Organizing Chairman, ISCOM, Dr. K.S. Lokeshwar Singh, Organizing Chairperson, Reception Committee, Dr. K.S. Achova, Organizing Secretary, Dr. Salam Ranbir, Treasurer, and of the dais, respected teachers, then seniors and students present, also friends from media. I am very lucky or happy to be part of this August gathering, Northeastern Diabetes Society 29th Annual Conference. I take this opportunity to thank the organizing committee for having me here for this important gathering that is intended to give lots of benefit to the larger society. And by now, I think Dr. Ranbir has just mentioned about the numbers and people living with diabetes. I think the number Dr. Ranbir mentioned was about 10 crore, but I think if you look at some of the very well-known Wikipedia and others, it's almost a double number. It's close to 200 million, something like is mentioned in some of the means I'm not an expert here, but I think numbers are variable. But by now, India is known as the capital of diabetes in the world. And even by now, we are the largest populated country in the world, and the number looks so what you can say frightening. And India by now contribute to about 26%. That is the number I have just read some time back. And by now, the number of diabetic people around the world in the last 3 decades has doubled, like from about 7% by now is close to 14%, means increase in the number. So we need to be really vigilant, and I think this August gathering is going to help us. We all know what are the basic causes of diabetes, but the modern epidemic of diabetic, if we look at, has been compounded by 2-3 factors. Obviously, we all know that obesity is one of the leading causes of type 2 diabetes. We can't do much about the type 1. But other than that, we, over the last, I think, decade or so, the very popular unhealthy, food marketing, the giants are there. So we have lots of, I don't want to name, but we all know how the foods are being delivered and how unhealthy are the diets by now. So obesity, there is unhealthy food, then lack of physical activity. These are the ones I means as a common man, you can say, will think about the major factors of the reason of increasing. So, and how we can, if we know this over a period of time, I think the physicians, when we talk about the number of endocrinologists, I think the general physicians need to help and educate the society how we can control this. We all know that we have a big body, the WHO, World Health Organization, taking lots of initiative on diabetes. And looking at this, rapid increase of diabetes, doubling the number in the last 3 decades, has awakened the WHO and other bodies. And by now we can read many things where the targets are being given, and by 2030 what is need to be done. So I'm not going to talk much about the modalities of treatment, but what the government or the WHO will be doing or is going to do to control this rapid increase of diabetic and that subsequent burden on the society. I think we have to educate the society. So the gathering will take the lead and advise, or obviously will come out with lots of points, easy points. I think that we are in a little bit of situation for last 1.5 years, so we don't need to talk about that. But the gradual education to the society, the common men who are suffering, who are not able to get the medicine, the basic medicines, we need to know how to give equity or distribution, that the government has to take the lead. So I was just looking at some of the points that in the last 2-3 years the WHO have taken up. So I quickly take another few minutes to mention few points before I conclude my speech here. So 75th World Health Assembly, WHO, in 2021-22 talk about 5 targets to be achieved by 2030. Like 80% of the people with diabetes to be diagnosed, 80% of the people with diagnosed diabetes have good control of glycemia, 80% of the population with diagnosed diabetes have good control of blood pressure, 60% of the people with diabetes of 40 years or older receive the cholesterol reducing drugs like statins. And the fifth one, 100% of the people with type 1 diabetes have access to affordable insulin and blood glucose self-monitoring. So these are some of the 5 targets started in around 2 years back with a target of 2030. And ultimately the aim is to reduce the risks of diabetes and move towards a world where all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, quality treatment and care, leading to what you can say, living with diabetes. Also Ranbir mentioned about the players living with diabetes. But we at some point have to look at the majority of the population who are diabetic are something like from these what we call low and middle economic countries like the Asian and African, and many of them are not diagnosed. So I think the August gathering has to suggest something to the government or the WHO points need to be collaborated with the state health missions or director is there for the state. So we at some point have to incorporate how we give affordable treatment to the diabetic patients, and that subsequently lead to a good control and a lifelong, the healthy, even though they are diagnosed with diabetes. So with those remarks, I think I once again thank the organizers for having me here, and I wish this August gathering, the 29th NESCON, a grand success, and I'm very sure that this deliberation will ultimately be beneficial to our society. Thank you. Thank you.
Thank you very much, our respected guest of honor, Professor Dr. G. Sunil Kumar Sharma, Director, REIMS, Lamphilpaat, for that enlightening words and for setting the tone of this event. Thank you so much, Professor. Before we hear from our respected chief guest of today's function, would like to request our respected chief guest and older presidium member to release the souvenir of NESCON 2024. Thank you very much for doing the honor. Now I would like to request our respected chief guest, Dr. Chambo Gonmei, Director, Medical Directorate, Government of Manipur, to address this August gathering.
Well, good evening to all. On this auspicious occasion, I should say, of the Northeastern Diabetes Society, Manipur State Branch, we call it NESCON. So NESCON 2024. 29th Annual Conference. It's a great privilege for me to stand before you today at the Northeast Diabetes Conference in the vibrant city of Imphal. As chief guest, I'm both honored and excited to be part of this gathering. As chief guest, I'm both honored and excited to be part of the gathering where we come together to address one of the most pressing health challenges of our time, diabetes. Well, respected guest of honor, Dr. G. A. Sunil Kumar Sharma, Director, REIMS, Lamphilpaat, and also our respected Dr. Y. Ipodan Singh, Organizing Chairman, NESCON 2024, Imphal, and Dr. K. H. Lokeshwar Singh, Organizing Chairperson, Reception Committee, and Dr. K.S. Chauba Singh, Organizing Secretary, NESCON 2024 Imphal, and Dr. Salam Ranabir, Treasurer, NESCON 2024 Imphal, esteemed teachers, my superiors, my colleagues, and all the PG students, and all the students of these RIMS, and all the participants and media persons. I was a bit surprised when the organizing secretary called me up to stand here to grace the occasion. And he is my colleague also, my friend also, and we have been working together. That time that was in, we call it Jain Hospital, not Jenims. And we really worked hard, I should say. And till today, I could see many of our faces who were there before, even our MS of Jenims now, who is, if I call his name, Dr. K.S. Lokeshwar Singh. Both of them, they were in Tausem many years back. And it's a great privilege for me to see them working so hard and, you know, flying high and then treating so many patients. And then, you know, they have been well versed with this kind of dreaded disease. We call it diabetes. Yeah, it is a global epidemic. Everybody knows it. But many of us are ignorant about this particular disease. And of course, as the year goes by and as so many programs are coming up, even from the NHM, we have this NCD, and people who are involved in these programs and all, they have been working so hard in many parts of the areas of our state. In all the districts, we have the district nodal officers, and under the guidance and leadership of our state mission director, we have been able to, you know, give out that kind of education and awareness and about all the non-communicable diseases, and particularly this diabetes and hypertension and all kinds of diseases. And it's not that easy to say that if you take like this, if you do like that, you can be prevented. Or if you do like that, your diabetes will be controlled. Or it will be healed. So many things are going on about these things. But then today's, I really appreciate in this NESCON had organized this scientific session, which is very important for all the PG students and all the, you know, scholars and teachers and tutors and senior residents and all. So I feel that we need to give maximum importance, because the complication of diabetes mellitus is horrible, I should say. But if we take care of it, if we take care of ourselves, if we love ourselves, I think we'll be able to prevent from this disease. Of course, some say that it is from their parents, genetics and things like that. But mostly everybody knows that it's because of our lifestyle. And then we need to understand that the lifestyle that we live in is, you know, comparatively so different from the olden days. In many years back, when I was a kid, with my parents, my grandparents and all, they used to go to the fields. Early morning they'll get up, and then by 5:30, 6, or latest by 6:30 they'll have their early meal. And then they go to the field. And then when they go to the field, then they have a lunch time, say around noon. They'll have some food and all like that. They sweat and they work, and then have some, say, fresh, curry and all like that. And then they'll work again, and the whole afternoon they'll work. And late in the evening, by 5:30, by sunset, they'll come back with fresh vegetables and all like that. Those days, no sugar, no nothing, except honey. We get it honey. And then we get all fresh fruits and all like that. And these people, they were so healthy. They hardly need to go to doctors for checkup and all like that. And they were healthy in the sense that in build-wise, and also their thinking, and then the way their mindset and all like that, it was so different. And then they have that kind of honesty that they live a very disciplined life. And those days we hardly hear about this disease, diabetes and things like that. But as the years go on, we're hearing a lot of this particular disease giving a lot of complications, like stroke and cardiovascular CVS, and then also all kinds of say complications on blood vessels and on kidneys. So all the organs are involved in complications. And we all know that, and the research is still going on to find a vaccine, but till now we have not able to get a vaccine for diabetes. And the only way is to prevent and change our lifestyle, and to prevent, say, from all kinds of the food, the junk food that we eat now. We are crazy after it. We find it very tasty, mouth-watery and all like that, but it is not that good for health. Many of us here are more expert than me. They know, you all know it very well. So I'm just comparing about how in the olden days, in the hill areas and all the people, they live. So I wish I could go back to that time. But now it's so different. Time never comes back again. And in this present age, I feel that we need to love ourselves and see that we have a very disciplined lifestyle. When we say lifestyle, it's a broad term. And then if we have to come to the specific points of the lifestyle, it's very difficult to say also. Some people say that I have been drinking for a long time, but I'm quite okay, I'm healthy, things like that. And some people, like in the village, I'm just giving some examples. They have a disciplined life in the sense that they drink rice beer. Those people who drink rice beer, they don't take to get drunk. They drink to be healthy. Rice beer thakpa haibse nohoi su thaklam su yai na. Adubo rice beer haibse ching de lebising di, like they used to take this rice beer before in the field also, when they come back home also, when they relax also, they used to have this. And then they lived up to 100 years. But now the lifespan of our world as of now is about, I think, 87 years, according to the survey. Aduna, like even now I'm seeing, just day before yesterday, I was also invited to be the chief guest of Amamikon, and I could see my very old teachers, more than 80, 90 years old, and then they're coming there for the function. And I was so glad to see them, you know, I was so happy, you know, how strong they are. And then it's because of the disciplined life that they lived. Even my grandmother, she lived up to 105 years. And then she never used to, you know, take all kinds of food from the market, things like that, you know, or from the grocery or things like that. She sticks to the, you know, kitchen garden, veg, and then from the fields and all like that. All the green vegetables, she stick to it. And whenever she takes the meat and things like that, also hardly 1 or 2 pieces. So a very disciplined life, they used to have it. Now we are not into that. We preach, but we don't practice what we preach. This is the main factor that many people are suffering from diabetes mellitus. And we can see a lot of people coming here in the ICU, diabetes complications and all, in RIMS, JNIMS, and all the private hospitals. Also, many people are referred outside for diabetes complications. Being the director of health, I'm also the state nodal officer or the chairperson of the reimbursement and state screening board. And when I see all those papers, the complication that they have are mainly due to all these kinds of diseases. When the treatment or kidney failure had, then treatment or diabetes, diabetes mellitus type 2, this thing like that. So, I mean, it was the way we live and the way we eat food, you know, different types of food that we eat, which is not suitable for our body. And many people, you know, they don't bother at all. I can see a lot of people, when I go for a jog, for a walk, or for walk and run at Kumalam Park, I can see a lot of people in the hotels. Puri do, thao se, numit miri mga lebigi thao gi, puri do charaga ko, cha thalaga wari saraga gossip toraga leba kangbu dini. Adu kangbu sing dini hospital de heng lari si. The sing na hai di ko. Aduna, and many of our seniors, our players also, out of playing football and then games and all, they have a big party and all like that. Adugadi Moisi, they get totally drunk, and then they don't bother about it. And the next day they'll play, and again in the evening they'll come and drink again. So, I mean, something, you know, very different. And then many of the players, highly disciplined, way they live a long life, aduga healthy life when sule, Miloi namak to heaven at day, adubu chatkiba, ahoy mrupsing su chatkiba yam legreva. Agi laikai da harise, even in my area. There are only 5-6 friends who are alive. Many of our friends, diabetes complication digira, atay digira, substance abuse digira, khangde, loine sakre. And sometimes I feel very lonely also. So my life se adum chatharga le rehaba. Aduna, I really appreciate our chairperson and then the organizing secretary, of this NESCON, organizing these things, and if we can bring more people, more students, invite more students and all like that, so that they can be sensitized properly about this, the importance of the prevention and treatment of diabetes mellitus, it will be very, very good. Aduga ngasi lakwa miyam singshu, I really appreciate you all, because I'm no better than you, and even in my lifestyle also, I'm also very ignorant. Yamna neglect to hai watanida. Aina neglect to wagi matam sisu yam leramne. Adubu, by the grace of God, I'm here. I'm standing here. Aduna akhoi se mi miyam sing se yaba makhai di akhoi gi hakchang yamna nungai na punsi sang na leise hairadi akhoi gi lifestyle se fajana change to badaka le yaba makhai di chini se kak thakro ba chini se khoi kak te ba. Even in the functions and all, we are still getting, very sweet tea. Dum phangnun le. So we know that it is bad. Aduga sugar say, but if you reach by the age of 40 years, no, sugar say totally cut down to khrohaim ne. Adu shu akhoi si toning de ba. Aduna we go for that kind of things only, but then gradually I'm seeing a lot of people koi gi function krigruma layer shu moi se chini yaw do budu piro da hai ba gum si go request dum to re hawa adum to ga akhoi se awareness the khrala khre adubo I like to request all our counterparts, all our seniors, friends, everybody to give more awareness in the interiors kangde, in the town kangde. Ngarang dusu asigi akhoi gi ima kathel da free checking of screening of diabetes tawduna le. Shiza Hospital and Babina also, and so many other advanced hospitals. Mohaina shu free treatment tawraga, free screening tawraga tawba haibise, because they love the people. We want to have a healthy life. We should have a healthy life. Ashine. Aduna akoina yaba makkay de akoina asum haina screening tawbisi, so reach out to the interiors also. Aduga akhoi gi imung da khakta oirachu education se phajana pibio, and even in the schools also asigi health ki curriculum se thambiraga akhoina asigumba se tawradi akhoi gi hakchang pharoi asum haina tawridi phagni habise. I think the teachers and all the parents and all, they have got the responsibility, not only the doctors or paramedical staff. It is the responsibility of every citizen, of everybody, to reach out to the people to have a healthy life. Only some, psychological problem leba, kangbu kaksana weakness leba, adugumba kangbu singsuna suicide tauba, tendency to suicide, adugumbagi attempted suicide kumbasi akhoi taewa. But many of us want to live. That is why we are bringing a very critical patient to the hospital for survival. They want to survive. So if we need to have a very healthy state, a healthy district, a healthy society, a healthy family, we need to live a very, healthy lifestyle. And then the way we eat, we have to be very careful. And then yabam khaidi junk food miyam sing se street labor gumbase akhoi avoid to se na khalle. And I used to like pizzas and KFC and things like that, but I feel that those are also not very good for health. Maybe I'm wrong, but then those who loved it, I'm not discouraging you, but I think we need to avoid all these kind of things. So let's have, plant more trees, more gardens. Shemlaga akoina yaba makhaidi yumda hoba akoigi inkhonda hoba fresh oibasingdo cha se na aidi adum hainingi akoigi inkhonda pukri leishnu nga fresh oibdu chao. We always go for the outside food. Aduna yaba makhaidi chini laiba carbohydrates laiba asi miyam se akoi se hanthare se cut down to se haina public ta mi miyam da adum haijaninge. Aduna I wish the NESCON for the next day also, for today also, and for the next day also, with the best wishes, and wish you all a grand success. Thank you all for giving me this opportunity. God bless you all. Thank you.
Thank you very much, our respected Chief Guest, Dr. Chambu Gonmei, Director, Medical Directorate, Government of Manipur, for your kind words of wisdom and for your encouragement that have truly aided immense value to this event. Thank you so much, sir. Now I would like to request our respected President, Dr. Y. Ibodon Singh, Organizing Chairman, NESCON 2024, Imphal, to deliver the presidential speech.
Respected Dr. Chambu Gonmei, Director, Medical Directorate, Government of Manipur, Dr. G.A. Sunil Sharma, Director, RIMS, Imphal, Dr. K.S. Lokeshwar Singh, Organizing Chairperson, Reception Committee of NESCON 2024, Dr. K.S. Saish Achauba, Organizing Secretary, NESCON 2024, Dr. Salam Ranbir, Treasurer, NESCON 2024. Delegates, colleagues, and the students, I thank all of you for gracing this occasion. Actually, NESCON 2024 was being planned on 23rd and 24th November. But because of the curfew and the adverse circumstances, it has been postponed. I congratulate all the members of the organizing committee for successfully organizing this conference in spite of all the difficulties and the handicaps faced by them. We all know there has been tremendous progress in the understanding of diabetes, its pathophysiology, and the treatment. There have been numerous trials about reversal of beta cell dysfunction, remission of diabetes, and I tell you, they have met with remarkable degrees of success. New technologies like automated insulin delivery devices, digital therapeutics, artificial intelligence, and data analysis, all these have helped the caregivers in the holistic management of type 2 diabetes. The incorporation of telemedicine and the smart mobile phone applications have helped in patient-doctor interactions. However, in spite of these advances, I feel that something needs to be done to prevent diabetes in our country, because India is the diabetic capital of the world. It won't be an exaggeration to say that most cases of insulin resistance are due to faulty dietary habit and the lack of physical activity. Therefore, if we include in the school curriculum for children chapters on healthy eating habits and benefits of physical activity, I think it will go a long way in reducing the incidence of diabetes. Because we never forget what we learned in our formative years. Imphal is a beautiful place with many areas of tourist attraction, but because of the adverse circumstances, we cannot visit them. I apologize to the delegates for this inconvenience. Lastly, let it be remembered that in spite of all the difficulties and the handicaps, we have kept the banner of Northeastern Diabetic Society flying high. Long live Northeastern Diabetic Society. Thank you.
Thank you very much, respected President, Organizing Chairman, NETSCON 2024 Imphal, Dr. Y. Iboton Singh, for that very valuable speech of yours. And now to formally close the inaugural function of NETSCON 2024, would like to request our respected Organizing Secretary, Dr. Ketumayum Achoba Singh, to propose the Board of Thanks.
Good evening, Honorable Chief Guest of today's function, Chambo Golmai, Director Health Services, for his presence here, gracing the function as the Chief Guest. Actually, I had a few difficulty whom to be chosen as the chief guest of today's function, because of SR has already mentioned there are so many big issues in the state. Selection of a chief guest became a problem. I had a thought in my mind that I would request brother like Chambo Golmai. I had a phone call and he picked up the phone. I said, Dr. Chambo, you have to be my chief guest. He was reluctant. He was reluctant first, saying that I may not be the right person to grace the function as the chief guest. I said, you are eligible person as a chief guest. I request you to be the chief guest. And again he said, second line was, no, I cannot talk. I am not a good speaker. I said, it should be a very brief talk. On the stage, don't waste your time, and don't waste our time as well. But today I come to know that I have learned many things from him now. It was the lengthiest speech given by any of the dignitaries on the dais, I suppose. So thank you so much. And this is just a joke to cut. And because of your presence that we are here, and we feel that the conference is being successful. I can't say that my conference is successful because the hall is half filled or three filled, one third filled or not filled at all. So I can't say that my conference is all successful. So nonetheless, you are on the dice, so I feel that it is half successful. And thank you so much for your presence. And second, the same story goes, and I had to speak to Dr. Guru Aribam Sunil Sharma, the present director of RIMS. Of course, he is my brother. So he also consented to be the chief guest of today's function. He happily agreed to my request, and he also gave some insights to the present scenario of diabetes. I think we are learning so much from different corners of the society, and we are living within a diabetic scenario. So I am learning from everyone's insights. So thank you so much, Dr. Guru Aribam Sunil, for your acceptance as my chief guest. Thank you so much. And I should say, I cannot deny the presence of my own teacher, Sir Y. Boton. He has been here, he has been there in many forums as one of the resource persons. Without him, the functions become empty in the minds of many people. So his presence is an immense encouragement to all of us, because he is our guide, he is our enlightener, and he gives lessons and he gives many things. So we have to go to his footprints, and I wish if I can go to his footprints, then I'll be a successful person once again. But still, I'm trying hard to be like him. So I am unable to do it, but he is the chairperson of ISCOM 2024, and he is a great personality to be remembered. So long he is there, and I think he will be guiding us throughout the ISCOM, in spite of not having ISCOM 2024 here, but in near futures also ISCOM will be there in the state of Manipur in Fall. Yes, thank you so much, sir, gracing the function. And Tamolokeswar Chairman, Souvenir Committee, he is, I should say, he is nobody. He is nobody, but he is everything. Again, he is everything. Whenever I have, he must be quite busy with me, because whenever I have some doubt, I had to call him what to do. What to do, it's just to leave my faults away from my things, that I said to Ranbir also, I said, Tamolokeswar says, so do it. So Ranbir cannot deny him also. So this is what I do. When the electricity is not there, I said electricity in the hall is not functioning, so he is responsible. So I am not worrying. So he does. So while on the dice, I saw him calling the electricity people to send the electricity. So I'm not worried. While I'm in Jenims, I'm not worried when Tamolokeswar is there. So he is all the time. He is nobody, but he is everything. So this is what I feel. So thank you, Tamolokeswar. I can't say more than this, but he is everything for me and everything for us. Thank you so much, Tamo. And Ranbir, what do I say? I don't know. He is nobody again. But he stays 12 hours with me. I don't know, he stays 12 hours with me out of his busy schedule. I don't know whether he is acting as an organizing secretary or treasurer, or I don't know, but he stays with me 12 hours a day for the last 20 or 1 month time to organize this function. And sometimes I do get angry. I said, when he complains, I do said, do whatever you like. Do whatever you like. He won't say anything, but he will do. This is the peace of mind that I had. So he is giving peace to me, but he is doing everything also. So he is nobody again, and he is again everything to me again. So thank you. So we are going together for the last 20-30 years years, so we will be going together once again. Now, having said this, we are in the difficult time. We were planning, as Sir Iboton said, it was to be physical conference, but due to some problem, we are holding in a hybrid mode. It's a difficulty. I know, it's a difficulty. So most of the outside speakers are on the line, facing and giving quite a lot of trouble during the presentation. I'm sorry for that, I apologize. But one lone person, I should say, is coming from far and present physically. So I would like to show to everyone present here. Dr. Meadow, can I request you to be on the, with the permission of the chief guest, because he is the lone person coming from outside, Dr. Meadow, from Nagaland. He is the only one present here, physical. Please come on the dais. Please come on the dais. Because with great difficulty he is coming. Please do come. Because I salute to you that you are present here physically. Please be here. Please be here. So he is Dr. Meadow from Nagaland. He is the only person present physically from outside the boundaries of Manipur. Thank you so much, Dr. Meadow. I salute to you. Thank you. Thank you. And this is what I can say, and many more things that I would like to say, that many are present here, giving their little bit of help to me to organize this function, including, and 3 people are here. Should I mention or should I don't mention? I don't know. They are very close to me. There are 3 JRs of me endocrinology. 2 are female, 1 is male. Just to mention their names, one Toitoishana, then Ronibala, then Arnon. They have been here working, so I have been disturbing them, and they come at 8 a.m. They will go back at around 8 p.m. So I don't know, their fathers, parents must be wondering how my children are doing there in Jenims. I don't know. So this is the grateful attitude of my students, my JRs. And if I don't mention 2 people's name, it will be a great problem for me. One is Prasanta, another is Rosen. I can say, what do I do? People will think that I have done everything, but actually I have not done anything. But they are doing. But they are doing right from the computer service. Right from the computer service, communicating people, sending emails, confirming everything is their job. When not done, they get what? Scolding from me. They get lots of scolding from my side that you have not done like this. But I can't do it, but they are doing. When not done in time, I get furious, then they got some scolding. They don't retaliate to me. They are working still. Until tomorrow, day after tomorrow, they will be working. After the conference is over, my hands are free, but their hands are tied, and they will continue working. So Prasanta and Rosen, if I don't mention their name, then I will be in fault. So I'm just mentioning. So these are few, and it's a formality. People used to say that all the dignitaries on the dais and all the HODs that I invited, my own teachers, including Madam Bhaigavati, my senior Tamo LK Sarad, then Tamo Somorjit, then Isema Santibla, then Tamo RK being the observer, and Tamo Birendra. And one very furious person to be noted is Robinson Ningsen. Robinson Ningsen is a very, very furious person. I don't know, I'm afraid of him, but I regard him also. So, thank you so much, Tom Robinson, to be very furious. Thank you so much. So, you will be a part of NETSCON together forward. Okay, without the instructions of all these personalities, organizing a conference like this is not possible. So we are working, and all the sponsoring authorities of various pharmaceutical companies, without their help, I don't think sponsoring or organizing a conference is not an easy and is not going to be possible. Thank you to all the pharmaceutical companies sponsoring for us and getting the heart of our conference. Now, endocrinology is a part of diabetes. We have certain faculties, and just to mention, Ramesh Sharma, then Biona has been the resource person today. They have been here, and we are holding times. And all the speakers of today's conference giving resourceful thoughts regarding the knowledge of diabetes. Thank you to all the speakers, eminent speakers inside and outside the state. Now, this hybrid mode is possible because of a very, should I mention, I should not mention, I don't know, but he is nonetheless, Deepak is the one, is the leading for this hybrid mode. He is the computer in charge. He has been disturbed for quite a long, but he is still inefficient. I am saying that he is not efficient because he made the things interrupted during the speech given by many outside speakers. So don't mind Deepak. Please upgrade your knowledge of computer. Thank you so much in spite of all these odds. Thank you. And all the speakers and all the PCTs who are coming to present posters, then papers, and without their help, then our conference again is not complete. Thank you for all these remarks, and if anyone has been left out from my speech, beg your pardon, and I may not be complete, I may not be able to mention all the names, eminent ones, so sorry for that, and thank you for that, thank you so much, and long lived NETS, Imphal, and NETS, India. Thank you so much.
Thank you very much, our respected Organizing Secretary, NETSCON 2024 Imphal, Dr. Ketrimayum Achoba Singh, for that very detailed word of thanks of today's function. Thank you so much. With this, we conclude the inaugural function of NETSCON 2024. And thank you so much, all the respected dignitaries on the dais, for your gracious presence. And thank you so much, everyone. So after this, we will continue our scientific session.
Thank you, sir. Thank you very much, sir.
Sir Prashant. Stay clear. Yeah, clear. Yeah, sir. Your speech was remarkable.
Yeah, thank you. Come on, sir.
Yeah, that was really remarkable.
Really, I don't know how to talk also. Sir, very nice, sir. Very nice, sir. Very nice. Sir, your speech is so wonderful, sir. Yes.
Ladies and gentlemen, we will continue the previous session, the third scientific session on the topic, newer approaches in diabetic management. Each talker and presenter will give 15 minutes and 5 minutes for discussion. Once again, would like to request our respected chairpersons, Dr. S. Bhagavati Devi, Dr. K.H. Lokeshwar Singh, Dr. Robinson Ningsen, and Dr. K. Romeo Singh.
clear tꯧꯕꯤꯗꯕ ꯌꯥꯔꯣꯏꯌꯦ ꯑꯁꯤꯁꯦ
Hayingi thamjariba tongan-tonganba scientific session ahum ahanbada complications of T2DM ani subada updates on management part 1 ahum subada updates on management part 2 ahanba session gi presenter sing Dr. Maibam Bobby Singh ani subagi Dr. RK Banashri Devi ahum subada Dr. Rajesh Waikomamadi Mari suba paper presenter Dr. TH Surat Singh Anisuba session gi presenter Singh Dr. Vikas Bhattacharji, Dr. Taruni NG Amadi Dr. Mridul Das. Ahum Suba session gi presenter Singh Dr. Sudhir K. Jain, Dr. Sumidra Laishram Amadi Dr. Vipul Chaudhary.
So everything seems to be going in the wrong way.
Yeah.
Nothing is working after a short inaugural thing. Welcome back to the academic session. Our next speaker will be Dr. Manas Pratim Barua. He'll be talking on insulin usage and injection practices and determinants of lipohypertrophy in a large cohort of patients with type 2 diabetes from India. Dr. Manas Pratim Barua is an endocrinologist working at Apollo Hospital, Guwahati, Assam. Welcome, Dr. Manas Pratim Barua. Can you hear me? Are you on the line? Welcome. Yeah, we can hear you. Please, we are already behind schedule. Thank you very much for your presence. Can you hear me? Please proceed.
Thank you very much. That's one. Of course. Is it visible now? Okay. Thank you so much. So my topic today, I'll cut short my talk and I'll try to be quick. So basically, I'm trying to present my own work, which we have been doing for last almost 2 decades, and we have published 2 papers. So we have tried to see the insulin usage pattern and injection, whether they are related to lipohypertrophy. What is the current scenario, like people, how they are executing the injection practice processes. So basically, we all wanted type 2 diabetes being a progressive disease. So my talk today doesn't deal with type 1 diabetes per se. So type 2 diabetes patients, they do require insulin in the course of their illness, and this almost becomes inevitable when they are almost over more than 1 decade of diabetes. That is from the UKPDS data, we know that. So roughly 4 out of 10 patients with type 2 diabetes at any point of time in India are using insulin alone or in combination of different oral drugs. So we have actually worked on injection practice guidelines. So we have published a few guidelines that is a necessity and it has been well accepted. And these are the various side effects which you might see, like lipohypertrophy is a rubbery lump forming in the injection site. And no doubt we used to see them a lot in animal insulin era, but we do see them a lot now also, and that's one reason. One reason being people do not rotate their sides. That's a major issue. Lipohypertrophy, you can see here, it's a dent on the injection site, and we also see quite a lot of fibrosis, scarring in the injection site, almost leading to amyloidosis. And these are, naked representation. If you apply a high resolution ultrasound, we might pick up more and more. So that's what it's being shown. So I'll not go into details, but shortly, briefly, if you are injecting in the lipoatrophic or lipohypertrophic site, your insulin absorption is going to be worsened, and your glycemic control is also going to get worsened. So this is the first part of my talk. This is actually a publication which came up in 2017 and well accepted publication. So we did an audit of insulin usage and injection practices, a large cohort, and the primary objective was to assess the knowledge and practice of the patients with type 2 diabetes and the treatment. As regards first, the vital parameters of encompassing the self-injection processes, and to correlate these process parameters with hard endpoints like lipodystrophy, hypertrophy, and self-reported hypoglycemia and glycemic status. So this is the baseline. Almost sizable numbers of male and female both. The mean weight was 65.2 kilo, and patients were mostly literate. Actually, for any kind of knowledge, attitude, and practice study, you need the patient at least minimally educated. We only had 2% people who were illiterate by the current guidelines, current standard. And we also did a diet and exercise awareness score, and most of the people had an average score that they used to know what they need to execute or follow properly. And there are certain populations, like for diet 25% and for exercise 45%, who actually do not know what to do and what to execute. Only a very few people, like 7% in the exercise and 4% in the diet, actually they knew exactly what to do and they actually executed that is in letter and spirit. So this was a subjective assessment, but when you do on a visit OPD clinic where you can actually assess how the patient is doing so far as the diet and lifestyles are concerned. The data regarding smoking is also here. The glucometer usage data is also there. That is 68% had access to glucometer and 31% didn't have access. That was between 2006 to 16 in my clinic. And remember, these patients are not being treated in my clinic. The first visit itself, I will capture the data and I'll compile the data based on that. So my clinic will start from here on. So this actually what is happening at the level. So these patients were using insulin plus oral drugs 50% and insulin alone 47%, and most of them were using metformin. So metformin is the largest component for accompanying drug of con medication, along with sulfonylurea being the second. And those days, you have much use of big-4 inhibitor, that was 15%, and you cannot find a SGLT2 inhibitor because by 2016 we didn't have many patients on SGLT2 inhibitors. And this is actually a kind of tells you what is the HbA1c status. And these patients, remember, these patients are using insulin. The mean is for 4 years of uses of insulin, and they had diabetes for almost 12 years till their insulin therapy started. And I'll come to that later on. They actually receive almost about 30% of insulin per day. Still, the HbA1c is going high. The mean HbA1c is 9.12 and maximum is 19.8. Then that's actually tells us that although we have initiated on insulin in these patients, a lot of things have to be done for intensification. So intensification is something we missed off, at least in periphery. So once given insulin is given, that doesn't actually give the best result unless we intensify the treatment properly, and that's one lesson we learned from this patient. Only 13% of patients who are on target, that is less than 7%. If your target was very stricter, then actually it's less than 6.5, only less 9.336, but then less than 1 out of 10 patients, only less than 1 out of 10 patients achieved the target of 6.5 HbA1c. So actually this is again another interesting type, but due to paucity of time I will not go into details of this, but actually it shows the status of glycemic control as regard to duration of diabetes when insulin was initiated. You can see that subject with less than 1 year diabetes initiated in 9, that is 8.65% and population, and more than 15, that is 24 is 22%. So basically you can see that if your diabetes is on the right side, if your diabetes is shorter, the physician tend to start only when the HbA1c reaches at a very high level. But they tend to start insulin in a patient having long duration of diabetes, even if the insulin is, even if the HbA1c is less. And then because the patient must have received a lot of drugs, a lot of titration must have been done, still the patient was not on target. Then probably the A1C cutoff for starting insulin comes a bit lower when the duration of diabetes is longer. That's what was reflected in this study. And patients, 59% of these patients till 2016, 2016, they used human insulin. Analogs were used by 36%. Combination of analog and human, which is still being practiced in our part of the country, that is was 5%. And for insulin analog use, we compared the data with some Japanese studies and Gulf studies and other studies like India, from India, diet care studies, for B1's diet care study. It was similar to Indians, but for Gulf countries, I expected the insulin analog usage was much higher because that is being supplied in their country free. In Japanese, interestingly, they still continue to use, at least in 2016, continue to use a lot of human insulin, and their analog data is comparable to us. And 31% of our patients use syringes, and 66% of patients use pens, which is again, you can see here, quite comparable to some studies. You can see here that from mosaic study I am comparing, for China, Germany and Russia, the pen usage is surprisingly, we are doing as good as USA. USA is only 40, just 40%. So India, the other studies from India is about 60%. So we are in that range, 60%. So we do reasonably better than many other developing countries are using pen. And in Northeast, pen usage is much higher than the country. Northeast average is higher than the average of Indian, other part of India. Sorry. So Insulin was, as I said, that 33.36%. The number of injections was 2, mostly, and that's because the patient used to take 1 to 5 injections, depending on the regimen. But mostly amongst our patients, most of the patients actually use premix insulin. That is a common practice, at least in those days when basal insulination was not very popular. So obviously, when you use premix insulin, the number of injections is bound to be bound to be around 2, mostly 2, and that's why you find that mostly in the patients you use 2 injections. And this is the relationship between patient practices, whether they are doing right or wrong. And if you look at the injection site rotation, again there's a huge gap. 69% were using wrong site rotation, and again timely needle changes, that is not using needle time and time again. That is 72% of patients were reusing needle. We didn't have counts like how many times the patients were using needles, but these are obviously more than 4, 5, 6 times. Same needle being used for 4, 5, 6 injections. So that's a big number. We continue a study where we are trying to find out what is the average number of injections a patient would use with a single needle, and whether that particular number is related to the HbA1c changes or lipohypertrophy. That study is going on. So regarding lipohypertrophy, our study found 12.5% lipohypertrophy, and GPR study from South India around the same time found 11.1%. The worldwide survey, Hirsch et al., they found 13.8%. Of course, they have better trained people to pick up lipohypertrophy. One study from Spain, where they used visual inspection plus ultrasound, which is a very sensitive tool. They picked up 64.4% lipohypertrophy amongst insulin users. So probably we are under-reporting lipohypertrophy because in a busy clinic, picking up lipohypertrophy, although we try to do it in each and every patient, sometimes we miss out. Nevertheless, because of less numbers, we didn't have significant difference in lipohypertrophy in terms of HbA1c or in terms of hypoglycemia. But of course, we found that amongst human insulin users, lipohypertrophy was 40.7%, and amongst analog insulin users, lipohypertrophy was 8%. Again, tells you the prevalence of lipohypertrophy according to different injection practice. This is the most important message I want to give. The most important correlation was found with injection site rotation, not even the needle reuse. Although that was, it was also statistically significant, but it was hugely significant, and that's why my message is, if we get a single message to the first message, rotate the site properly, then probably we can avoid a lot of lipohypertrophy. Second, of course, is nuisance, which of course is it's a very important social issue, socio-economic issue, because needles are getting costlier and costlier, and how many times you can reuse the needle. That again, someone has to do a scientific study to find out, and I'm trying to do that, because asking the patient to change the needle every time is also too much actually. Sometimes patients actually cannot be a doctor. They may not spare that much of money only to buy the needles, and that again actually is a deterrent for continuing insulin therapy. So you have to be very careful. But probably from my practice, I have learned that we cannot allow the patient to reuse needle beyond 3-4 times. I think that should be the optimum, if not the single time. At least 3-4 times, that's the maximum, not beyond that. So with this, I will stop here because I know the organizers have paucity of time, and I think I have given you the strong message regarding importance of asking the patient to rotate the site to avoid lipohypertrophy. And I also gave you a picture as to what is happening in the background, like how much of patients are using analog and human insulin, and how the injection practice is actually happening at the grassroots level regarding our patients. So it reflects what is happening mostly in Northeast region. Assam in particular, in general, Northeast region. With this, I will end my talk so that I can spare some time to the esteemed speakers who will follow me. Thank you very much, Asrupa, Ranbir, and others in the organizing team. Thank you, Chairperson, and thank you, Chief Governor.
Hello. Thank you, Dr. Das. It was a very nice talk. Barua, sorry. It was a very nice talk. Can you listen? Can you listen to us?
Yes, yes.
Yeah. Very nice talk from your side. As the time is running out, there will be no question from the delegates or the audience. Thank you for your kind presentation. Thank you.
Thank you.
Would like to request respected chairperson, Dr. S. Bhagavati Devi, Madam, to be on the dais once again, and would like to request our respected speaker, Dr. Bharna Konsum, to give us a moment to honor and felicitate you for your insightful presentation. Amadi ikai kumnajariba chairperson Singh, Madam na, speaker Madam Dr. Bharna Konsumbu ikai kumnabut pinabagi damagta nolukchari. Loinana session asigi chairperson oina linkshin bikiba singi mafam dasu ikai kumnabut pinabagi damagta Dr. L.R.K. Singbu nolukchari. Ahanbada Dr. S. Bhagavati Devi, former head of department, Reams Medicine. Madam Gimapamda, Ikaikuna Jaribasa, Dr. L.R.K. na Langjariba Link Madi Memento, Kudolta Miduna, Ikaikuna Ba Utpigani. Thank you very much. And next we have Dr. K. Lokeshwar Singh, Medical Superintendent, Chenims, and a respected member of this organizing committee. Thank you very much. And we have Professor Dr. Robinson Ningsen. Mathangi Aroiba session, updates in management technologies ki Chairperson Singh Mathang Linkat Piranaba Nolukchari. First we have Dr. Swapnab Borthakur, Dr. Samik Dev, Dr. L.R.K. Singh, Dr. L.K. Sarachandra, Dr. N. Somorjit Singh, and Dr. K. Santibala Devi. Would like to request our respected chairpersons of this session, Dr. Swapnab Borthakur, Dr. Samik Dev, Dr. L.R.K. Singh, Dr. L.K. Sarachandra, Dr. N. Somorjit Singh, and Dr. K. Santibala Devi. And two of our respected chairperson is joining online. Now we'd like to hand over the mic to our respected chairpersons.
Hello. Good evening, everybody. Today's next topic, next session will be advances in glucose monitoring system. The speaker is Dr. Shamiran Das. It will be online. It will be online. So,
yeah, am I audible and visible? Am I audible and visible?
Okay. Can you hear me?
Yes, I can hear you.
You can start. Time is late.
Yeah,
so
my slides are visible.
Please start. Shamiran Das, please start.
Yeah, good evening, sir. My slides are visible to you?
Yeah. You can start.
Shamiran Das, not audible. Your voice is not audible. Can you hear me?
Yes.
Okay, audible. No.
Gives us a glucose over the last 3 months. But though it has some advantages, it has some limitations as well, because it cannot show the magnitude and frequency of intra and interday glycemic variation, cannot show the extent or timing of hypoglycemia or hyperglycemia, and it has limited utility in insulin dosing decisions, as well as unreliable in certain conditions like anemias or kidney disease and hemoglobinopathies. So, to mitigate these drawbacks, we had this time range concept with continuous glucose monitor. So, using time range to complement HbA1c is because it identifies magnitude and frequency of the intra and intraday glucose variation. It shows us the glycemic excursion as well as extent of timing of hypo and hyperglycemia. So, this time and range concept adds valuable information to assess current glycemic control in addition to HbA1c. It is increasingly used in to compare interventions in clinical trials as well, and time above and time below range are useful variables for evaluation of treatment regimens. Of course, we have blood glucose monitoring devices, the point-of-care devices, which have for decades. These are affordable and accessible devices for self-monitoring of blood glucose. It allows the patients to have the control over the disease because it identifies hypoglycemia and hyperglycemia, get immediate feedback about the effect of food choice, stress, activity, insulin dosing, and determine whether medication adjustment is needed. New advances regarding BGM device is that they can be linked to apps and other digital data management technologies, and a personalized approach is recommended for BGM use with regard to frequency and type of diabetes. But it has its limitations because it only provides a blood glucose reading at a single point of time. It has very high non-adherence due to the pricks, pains associated with it, and only 6 of the top 18 glucometers meet accuracy standard. So recent improvement in BGM are less painful latching devices, meters that provide advice on actions to take based on real-time blood glucose readings, and newer machines can be used as a part of integrated health platforms. But the latest advance in this field is continuous glucose monitor, and this has improved quite a lot. The first beginning of the CGM has been in 1960s and 70s, so they were improved, and the sophisticated machines, the concept is old. But from the mid-2000s and in the last 5 or 10 years, the concept of CGM has catch up, and now we have the closed loop system as well. So continuous glucose consists of sensor, receiver, and transmitter. The sensor measures glucose level just into the skin. It is attached to the transmitter, which hits onto the sensor and sends data to the receiver. The receiver component, which has a display that can be programmed to alert when the glucose levels are too high or too low. So it has these 3 components. CGMs are basically wearable technology that measures blood glucose levels 24 hours a day when the device is worn. The sensor measures interstitial glucose level, which fairly correlates with the plasma glucose. The receiver can display the real-time glucose trends in graphs and direction arrows that allows people with diabetes to anticipate the approaching glucose highs and lows. The CGM device can help identify fluctuations and trends that would otherwise go unnoticed with intermittent blood glucose monitoring devices. So this slide actually shows a brief history of CGM technology. The first marketed CGM device is the Medtronic Minimed, which was marketed in 1999. This was a word sensor receiving connection device. It's an adjunctive CGM because it requires finger prick BGM every 6 to 12 hours to validate it. From that Medtronic Minimed, now in 2023 we have Dexcom G7. Though it is not available in India, this is the latest CGM device, which is the most accurate CGM device to date, and it is the fastest sensor warm-up to date. In 2016, there was a landmark event when the Dexcom G5 was expanded indication approved by FDA to allow for replacement of fingerstick BGM. Prior to that, blood glucose monitoring has been in association with CGM devices. So the future direction of CGM is the artificial pancreas, which Dr. Dinesh sir has also talked about. The CGM device combined with autonomous insulin delivery system or pumps with function beyond current 3-day limitation. So they are actually the artificial pancreas. There are multiple benefits of CGM device. It provides more detailed and actionable information that helps in initiation and optimization of the therapeutic agents, captures the important dynamic variations in blood glucose levels. From the Diamond trial, it was found that the CGM is superior to SMBG in achieving glycemic control and reducing HbA1c level, and a 38% decrease in time spent in blood glucose level less than 3.9 nanomole per liter results into effective reduction of hypoglycemia. So, in contrast to SMBG testing, they are better so far as hypoglycemia is concerned. Again, intermittently scanned CGM significantly reduces the risk of hypoglycemia and improved HbA1c. Good correlation exists between percentage time in range data and HbA1c. So 10% change in TIR correlates with almost 0.8% change in HbA1c. We have a whole body of evidences regarding CGM device and its role, be it the decreased HbA1c, decreased number of hypoglycemic events, increase in TIR, decreased hospitalization, decreased quality of life and satisfaction, as well as decreased absenteeism. So most of the data which we talk about are from the freestyle liberal system, which is widely available in India from about health sciences. So this is actually an intermittently scanned CGM or fast CGM which I'll be talking about. So the data are from variety of studies like selfie, Press UK, which is done in type 2 diabetes mellitus, or ERM study in type 2 diabetes mellitus, or replace study in type 2 diabetes mellitus. Most of the studies have shown beneficial effects of CGMs. Looking at the safety device, the overview is in this chart. So the device is basically of two types. The blinded one, which we healthcare providers can use for retrospective data in clinic setting, but the newer molecular machines are unblinded and they can be intermittently scanned CGM device or real-time CGM device. In India, at present, we have intermittently scanned CGM device, which are also called flash CGM device. The freeze delivery is a flash CGM device where we measure glucose levels continuously, but it requires scanning for storage of glucose values, and we have to scan at least once in 8 hours. It displays glucose values when swiped by a reader or nowadays a smartphone, and it has a disposable device with or without alarm function. The RT CGM, the ISCOM has the most of the real-time CGM machines, which are unfortunately not currently available in India officially. They measure and display glucose levels continuously and without prompting. They also have this alarm function, which are automated and gives highs and lows as per the direction from the caregiver or the patient itself. So the unblinded machines are owned by the user and they are intended for frequent and continuous use. So most of the functions of the RT and ISCM are similar and interchangeable, except the alarm function, which is exclusive in the real-time CGM. However, the newer machines in the ISCM category are also having alarm functions as well. So real-time CGM device, which gives a continuous real-time display of glucose level, are suitable for integration with insulin pumps, and they can be useful for making dose adjustments or predicting hypo and hyperglycemias in patients with diabetes. So the replace BG trial, which actually have compared CGM only and CGM plus blood glucose monitoring only, has actually shown that in adults with well-controlled type 1 diabetes mellitus at low risk of severe hypoglycemia, utilizing a continuous glucose monitor without regular confirmatory BGM is just as safe and effective as with confirmatory BGM. So from adjunctive function to non-adjunctive function, the continuous glucose monitor has actually upgraded in place. So now we can use it as a non-adjunctive function. So briefly into the closed loop insulin delivery system, though this is the insulin delivery system, but the advancement of the glucose monitoring is integrated in this system. So this is basically an artificial pancreas, which is its system for automated insulin delivery, and it will liken to holy grail of diabetic management. Here, glucose monitoring works in tandem with insulin delivery via control algorithm, and more artificial intelligence is being employed. The JDRF, or Juvenile Diabetes Research Foundation, was established, the Artificial Pancreas Project, in 2005. So it aims to promote the research, regulatory approval, and eventual adoption of the closed-loop technologies. Closed-loop CGM system represent a significant advancement in diabetes management and control and quality of life for people living with diabetes. So from this JDRF, we have 6 categories of closed-loop system. One is very low glucose insulin off pump, one is hypoglycemia minimizer, one is hypoglycemia and hyperglycemia minimizer. The fourth or second generation is the automated basal hybrid closed loop, where the closed loop at all times with mealtime manual assist bolus. When this manual assist is replaced by an automated function, it is the second generation, number 5. And the third generation is fully automated multi-hormone closed loop, which employs both insulin as well as glucagon for hypoglycemia. So what's the future? These are the newer updates which are coming into the picture. So next generation sensors have longer lifespan and accuracy. Also, development of the microneedle sensors, which minimally invasive sensors, are very much comfortable for patients as well as cost effective. There are some non-invasive monitoring technologies being employed in research setup. One is wearable device. So wearable device is a device which don't require pricking of skin, such as those using infrared spectroscopy or electromagnetic techniques to measure the glucose level through skin. Of course, we have this closed loop system which I have talked about, and this Medtronic MiniMed 770G, Dr. Agarwal sir also mentioned regarding this. It uses the CGM data to automatically adjust insulin delivery, helping to maintain optimal glucose level without constant manual input. Again, artificial intelligence and machine learning are being employed more and more frequently. So predictive analytics has been used. Advanced algorithm analyze pattern in glucose data to predict future levels, helping to optimize insulin dosing and improve diabetes management. Again, we have data visualization devices now where apps can be used to show the patient regarding their data, and they can actually titrate their doses. The regulatory advances are also there. So hybrid system has been approved. So new hybrid closed loop system have received regulatory approval, allowing for more responsive insulin management and improved user experience. So this advance collectively enhance glycemic control, improve user experience, and empower individuals with diabetes to manage their condition more effectively. So briefly, the newer technologies. One is microneedle. So these painless, stable, and low-cost microneedle sensors actually are their patches. They are patches, and they can extend the scope of CGM to other categories like pre-diabetes, type 2 diabetes, and gestational diabetes. They use this FRET-based sensor, FRET, resonance energy transfer. They have basically glucose-specific phenylboronic acid attached to it. So the optimized hydrogel sensor enables quantification of glucose with reversibility, high selectivity, and signal stability against the photo bleaching. The fluorescent signal of the microneedle patch can be automatically converted and wirelessly transmitted to a smartphone or a portable reader by the integration with a blue LED, a sensitive photo detector, and signal processing unit, and an NFC chip. So this can give us accurate reading without pricking or with minimal painless pricking. Non-invasive devices are in range now. They have been more and more being researched because of their comfortable nature. Most non-invasive blood glucose monitor technology rely on the quantification of glucose molecules that exhibit distinct characteristics in different light frequencies such as ultrasonic waves, near-infrared, and visible light. While these methods enable real-time quantitative monitoring, they do not offer the same level of accuracy as traditional electrochemical blood glucose meters in clinical settings. That is one of the drawbacks of these wearable devices. So few of the methods employed is one is gold nanostructured programmed flexible electrochemical biosensor. This has been developed by Yu-Chi Lin et al. And they are basically a nanocomposite layer of this NGQDS PANI electrodes. So these electrodes have actually some immobilized glucose oxidase incorporated into them, and they basically utilize the glucose oxidase function. But they measure the sugar values in the sweats. So, but these wearable devices which employ the sweat as a measuring medium have faced certain challenges because the electrochemical performances when subjected to deformation is a bit faulty, which can cause cracks and damage to the electrodes. One is nickel oxide nanosheet using graphene oxide film. It is developed by Heian et al., which use the graphene oxide film as a template to prepare novel nanoparticle assembled nickel oxide nanosheet that can also measure the glucose values in blood as well as other interstitial fluids. Another is electrochemical twin channel high sensitivity biosensor. This was developed by Yihao Chen et al. From Japan. They actually have manufactured a high precision blood glucose monitoring by integrating the ultra-thin skin-like biosensor with electrochemical twin channel powered by paper batteries. The design certificates etc. could extract blood glucose from the blood vessels and transport to the skin surface. So they mimic the plasma glucose concentration. Near-infrared spectroscopy have been employed for many years, and the technology is being refined every year. So near-infrared spectroscopy generally selects areas with rich blood vessels and thin skin like tongue, lip, earlobes for measurement of the glucose. One interesting new technology is optic rotating method. Here, actually, there are multiple transmitting lights which can be linearly polarized. So polarization through the glucose molecule has been employed in this method.
the detection of the glucose molecule can be achieved using a fiber optic sensor based on the principle of optical rotation. Microwave sensors are also being employed. The principle of microwave sensor is to measure blood sugar level by utilizing the reflection and absorption of the microwave signals when they pass through human tissue. These sensors determine blood glucose level by measuring the complex electric constant in the blood. Another interesting and upcoming technology is electromagnetic sensor system. Jessica Hanan et al. Have been working in this regard, and this is a wearable multi-sensor system for high-sensitive, non-invasive continuous blood glucose monitoring. It comprises of multiple band slot antenna. Each sensor will perform non-invasive and continuous monitoring of the different disturbance factors, forming an integrated glucose sensing system. This is vascular anatomy mimicking electromagnetic sensor system, which is wearable. So this is most promising research purpose as of now. So hopefully in near future we can get benefits from this newer technologies. So till now, CZ, especially our part, freestyle Libre system has been employed in many patients, especially high-risk patients like pregnant patients, CKD patients, to get their day-to-day fluctuations and glycemic variabilities. But non-invasive methods are very much promising.
Dr. Simran Das, can you hear me? Hello, can you hear me?
It will be a great boon. So with this, I want to end my deliberation. Thank you very much for patient hearing.
Okay. Thank you, Dr. Simran, for your elaborate explanation of the this glucose monitoring from the beginning to the latest and the future also. As the time is constrained, we will not have any question from the audience. Thank you, Dr. Simran, for your elaborate this thing, and the future will be with the adventure of these technologies and the artificial intelligence. We will like to have non-invasive, cost-effective, easily accessible instrument which can be available to the public. Till now, we have to wait for the thing. Thank you.
Thank you, sir. Thank you.
Hello. The next speaker, I request Dr. Indira Maisnam to come to the stage, and she will talk a very interesting topic, present a very interesting topic, path-breaking innovation in diabetic therapy. Dr. Indira, please. And time allotted is 15 minutes. Where is Dr. Indira?
Can you say a very good evening? Is my screen visible?
Yeah, it's visible. Okay. Please carry on.
Yeah. Is it moving?
We can see the first slide. Second slide we cannot see. Dr. Indira, you have problem in presentation. You can keep on speaking from your laptop or computer, and in the meantime somebody can help you for the slides. Okay, please carry on.
Not sharing. It is being shared, but okay, so I'll just thank you very much. It's really unfortunate for me that I am unable to be present in my dear state for the next call. So so my topic is the path-breaking innovation in diabetes, and we have actually, it is a summary of all that we have had in the past few minutes or hours. Is it moving now?
No, Chetake, please carry on.
Is it moving?
No, it's not moving at all. Yeah, it starts moving. Okay, please carry on. Please make it larger. That slide.
So, is the slide on the Fantastic Four of insulin discovery showing?
Yeah, it is there, but you can just go to the right hand side and press on that cup so that it will become larger. Just near the volume open resolution on. Yeah, it's okay. You can keep on presenting. We can see it. Thank you.
Fine. So, it has been more than 100 years since there has been a discovery of insulin, and we have gone through very many progress in the discovery of insulin. So I shall talk about many innovations, but briefly because we have covered almost all of them. So it will consider insulin, it will consider the bariatric surgery, the path-breaking innovations in the development of molecules, of already monitoring techniques, islet cell transplantation, and also artificial pancreas, which is already discussed. So these are the different technologies which we have for the delivery of the insulin pens. Now the idea is to prolong the action of insulin, and for this we have had many advances in the development of basal insulin. That is, for example, the latest generation basal insulin, the insulin degludec, which has a protracted mode of action because it is a dihexamer, and then it slowly diffuses to release the monomers over the long time, and thereby the duration of action is prolonged. It is effective and safe in patients with type 2 diabetes, as we can see in a lot of studies. Another long-acting insulin is a U300 glargine, but this is a more concentrated form of the glargine which we know, and which would actually prolong the action by being more concentrated, and as a result of which less glargine is slowly released into the circulation. Along with this, other advances are the co-formulation, where we have the degludec, which is co-formulated with an aspart. So we have the IDEC aspart, which is a better preparation than a premix insulin, which we are already using. And IDEC aspart is therefore the world's only co-formulation insulin, and it is also recommended by the RSSDI 2022 for its for use in patients with diabetes for initiation as well as for the maintenance. Now, these are some evidences about the degludec, where we have the real-world study, where we have seen. This is about the this was about the combination, that is the IDEC aspart, where we see that it is much more effective than in patients for the control of blood glucose.
No, your slides are not moving.
I don't know why it's not moving.
Yeah, carry on, please. It's very nice one. Oh, it's moving, Indira. You can carry on. The thing is, you can just press on the cup on the right side, then it will become enlarged and will be easier for the next presentation. Otherwise, you can carry on, no problem.
Something. Actually, I think some part of my thing has not been activated. That's why I'm unable to share, I think. I'm unable to move. So should I continue or?
Please carry on. From your desktop or laptop, doesn't matter. Carry on, keep on talking. Okay, thank you.
So IDEC aspart could be a good insulin for the initiation of insulin. So in other words, for the advances in the insulin, we have the longer acting insulin analogs. We also do have the short acting or the rapid acting analogs, which I shall not go into details. We have also had a revolution in the development of the oral anti-diabetic agents. Initially, our let's say management of type 2 diabetes was based on the symptomatic control of hyperglycemia, but over the years we now know that many agents are responsible for the modifying the natural history of the diabetes, and this includes, for example, the SGLT2 inhibitors, the metformin even, and the incretin groups of drugs and piodators. Some understanding of our management of diabetes has been discovered serendipitously, in the sense that when patients underwent bariatric surgery, the benefits which was seen with bariatric surgery actually outweighed or was much more than what was expected. And because of the benefits of the bariatric surgery, we came to understand about the various mechanisms by which bariatric surgery results in weight loss. And this results, as we can see, the bariatric surgery improves not only the HbA1c, but also a significant weight loss compared to lifestyle modification. And the understanding of the mechanism of actions of bariatric surgery has led to the search of the incretins, and now we have a number of incretins. To start with, we have the GLP-1 receptor agonist, which has been there for a long time now, and which have multiple favorable metabolic effects, whether it is weight, adipose tissue, glucose metabolism, and cardiovascular effects. And now the oral forms are gaining popularity, and in the next decade, the oral GLP-1 receptor agonist, it started with the semaglutide, oral semaglutide, but many are in the pipeline which are non-peptide oral GLP-1 receptor agonists, and they are going to be the major molecules in the next decade, like the gliptins has been in the last decade, gliptins and the SGLT2 inhibitors. But also beyond the GLP-1, we also now understand that many other molecules are also involved in the control of glucose as well as the body weight in patients in diabetes. And so we have bi-agonists where there is GLP-1 receptor agonist with a GIP receptor agonism, or even tri-agonists where there is a GLP-1 receptor agonism with a GIP and glucagon receptor agonism. And these type of molecules, whether it is for example, we have the retatrutide, and firstly we have the tirzepatide, which targets both the GLP-1 and the GIP, which has got significant weight loss, and also which even exceeds the amount of weight loss that is produced by bariatric surgery. And then we have others that are coming like retatrutide and so many other molecules. So the mechanisms of actions of GLP-1 and GIP, we know that they control the hyperglycemia, but for the want of time, I'm not going into details about the mechanism of action, but also they cause significant weight loss. And when these two are combined, there is an additive effect on the weight loss. So, and glucagon also, even if it increases the blood glucose, it does, but it also is a molecule that significantly causes blood weight loss, and thereby the combination of GLP-1, GIP, and glucagon would target the glucose by the GIP and GLP-1, and the glucagon, GIP, and the GLP-1 would target the body weight. So these are advances in the medical therapy which we can see, and we have a number of evidences with molecules like retatrutide, like tirzepatide, and so many others in the pipeline. Now coming to the type 2, regarding the medical therapy again in type 1 diabetes, now we have come to a stage where we can at least prevent or delay the progression of type 1 diabetes. And so teplizumab is the only FDA-approved drug to prevent the progression of type 1 diabetes. It has got immunomodulatory effect and anti-CD3 antibody, which enhances the activity of the Treg and therefore is anti-inflammatory. So it was found to preserve insulin production and reduce the requirement for exogenous insulin in patients with new onset diabetes. It also reduced the C-peptide loss and need for exogenous until 2 years after the diagnosis. So it's a small thing that we have been able to achieve. That is, we are able to delay the development of the manifestations of diabetes or decrease the insulin doses. So these are the early stages in the development of the prevention of type 1 diabetes. But over the the coming years and decades, it is hoped that type 1 diabetes could be prevented. And there are many other studies which are going on regarding the prevention of type 1 diabetes. And if type 1 diabetes cannot be prevented, and if it needs, is it possible to actually have pancreas transplantation or pancreas kidney transplantation, or more specifically, could we have the stem cell transplant replacement of islet cells, and even more specifically, could we have gene therapy? So there are many studies that are going on. There are on pancreatic and islet cell transplants using the full pancreas transplantation, but also human islet cell transplantation. And when to consider in type 1 diabetes, recurrent severe hypoglycemia, hypoglycemia unawareness, brittle diabetes, difficult hypoglycemia with stable functioning kidney graft, recurrent DKA, and rapidly progressing type 2 complications. Also, pancreatic transplantation may be considered in those with acute and chronic pancreatitis, cystic fibrosis related pancreatitis, trauma, and benign lesions. So these are the type of pancreatic transplantation which are there. It could be only pancreas or pancreas and kidney transplantations. But more specifically for type 1 diabetes, what is undergoing in advanced stages of research is the autogenic or the allogenic transplantation, where there is blood group HLA matching, extracted islets, cell culture and purified, and transcutaneous mini laparotomy. It is transplanted into the liver and encapsulated, and eventually to develop own blood and nerve supply. So this research activity is going on at full pace, I would say. What are the islet alternatives? It could be stem cells derived from the beta cells, or porcine cells which are genetically engineered. So there are advantages and disadvantages of islet cell stem cell derived transplantation. The advantages is that the ability to proliferate and differentiate indefinitely, easy to genetically engineer, potential for standardized industrial production, and encapsulation reduces immune rejection, but difficulty in vitro differentiation, lower functional performance of stem cell derived islet cells compared to primary human islets, and use of different pluripotent stem cell lines and protocols. And for the porcine islet, it is easy access to donors. Functionality is similar, but immune rejection due to xenotransplantation. So what is more promising is the stem cell derived beta cell. And the rationale of transplantation is that it could control the hyperglycemia, it could control the glycemic variability, decreases the chances of hypoglycemia, and reduces the progression to complications. Artificial pancreas has been discussed very extensively by my previous speakers, so I'm not going into the development of artificial pancreas, which is also known as the automatic insulin delivery system, where there is a CGM system and where there is a infusion system, and then there is an evolution of the loop over these years, and more evolution is expected in the form of model predictive control algorithm. So in the
Dr. Indra, can you sort a little bit?
It tries to understand the glucose is like a chess game, in the sense that it tries to understand the pattern of the glucose and determines how the glucose should be infused. But only the first 15 minutes is infused, and then thereafter, according to the pattern of the glucose response of the individual, the infusion protocol algorithm is derived. So the loop evolution is something that is an answer to the islet cell or pancreatic transplantation. So more and more advances are expected in this, and obviously there are advantages: higher time in range, lower time below range, reduced hypoglycemic events, and thereby less complications. So to conclude, there has been moments of discovery and innovation, but we need to remember that every success as well as failure was important, because the failure was important in guiding us where we were wrong that would lead us to success. So the promises are many in the path-breaking innovations of diabetes, whether it is in the development of insulin the novel insulin, the technology of insulin delivery or monitoring, the technology of insulin infusion, the advances in the drugs that are treating diabetes, which we now call the anti-hyperglycemic agent with extra glycemic benefits, because they do not cause hypoglycemia. So we don't use the term hypoglycemic agents for this, but rather anti-hyperglycemic. So they control a high blood glucose, but do not lower a normal blood glucose. They are also known as the disease-modifying agents of diabetes. More and more of these molecules, especially in the forms of different types of incretins, are coming. Some inventions and discoveries were also made serendipitously. That is a very, let's say, a very happy chance that we found. For example, in the case of bariatric surgery, because bariatric surgery was done and the benefits of bariatric surgery outweighed the what was expected, that's how the advantages of incretins were developed, and therefore human intellect, valor, grind, luck and chance will all contribute and have all contribute to where we stand today and where we will be in the future. Thank you.
Thank you, Dr. Indira. Can you hear me? Hello? Can you hear me?
Yes.
Yeah, it's a very good presentation. You might be a bit tired in waiting for the program slot, so I won't allow anybody to ask you. Thank you for your beautiful presentation. Thank you.
Thank you. I think sorry for the glitches in the slideshow.
Okay. Doesn't matter. Okay. Thank you. Thank you for a beautiful presentation. We're enlightened by you. Okay, thank you.
Next we will have a very good topic. We have discussed all about diabetes now. For today, we are finishing with non-diabetic kidney disease. I think it is offline. He is none other than Dr. Gulliver Pochambam, nephrologist, who is for kidney and well-being. So I welcome Dr. Gulliver Pochambam on the stage. He's a consultant nephrologist. He's a hospital and a research institute, Langol. So Dr. Gulliver Pochambam, your time is 15 minutes, so you can start.
I'll just wait for the slides to load up. And in the meantime, thank you, chairpersons, for the kind introduction. I'm grateful for the opportunity to give this talk. So senior consultants, good evening. Colleagues, ladies and gentlemen. My topic for today will be non-diabetic kidney disease in patients of diabetes mellitus. So can you have the slides, please? It's over here. So I'll go straight on to the topic. So with changing non-diabetic kidney disease in patients of diabetes mellitus, so with changing epidemiological and therapeutic practices, we have had changes in the spectrum of renal involvement in type 2 diabetes mellitus. Now this entity is important because it differs from the diabetic kidney disease, because many times and often it is reversible. Biopsies are usually required for rapid diagnosis and treatment, and data is scarce regarding these entities. I'll try to present some of the data which is available. So the course of this talk will be, I'll be briefly speaking about the natural course of diabetic kidney disease, non-diabetic kidney disease, the predictive value of diabetic retinopathy for diabetic nephropathy, other predictors, types of non-diabetic kidney disease in these patients, and a few case scenarios. So the natural course of diabetic kidney disease, we know that these are the Mogensen staging. Patients who have diabetes mellitus, especially type 1 diabetes mellitus, will have a case of, is the stage of hyperfiltration, then the stage of silent nephropathy, then incipient nephropathy, whereby they develop microalbuminuria, then they would develop overt nephropathy where they have macroalbuminuria, also known as severely increased albuminuria. Then they would have a decline in GFR followed by end-stage kidney disease. So this staging is frequently seen in type 1 diabetes mellitus, but not frequently seen in type 2 diabetes mellitus because of some factors which we know. So when they saw patients of type 1 diabetes mellitus, these patients were seen in the Jocelyn Clinic. They saw them about 240 patients of type 1 diabetes mellitus, and they were followed up for about 7 to 18 years. And they saw that a large number of these patients were either non-decliners or slow decliners. So, and about 1/4 of these patients had rapid decline. Rapid decline in the sense that they had a fall in their eGFR between 7 to 13 mils per minute per year. And they progressed to end-stage kidney disease within 2 to 10 years. So and another quarter of these patients had moderately rapid decline, that is somewhere between 5 to 7 mils per minute per year, and they progress more slowly. So and about half of them had very slow decline. Either they did not progress at all, or very few of them developed end-stage kidney disease. Now, I said they are different from type 2 diabetes mellitus because the trajectories of type 2 patients could be different. We could have different phenotypes. One is the classical phenotypes, which we know they develop microalbuminuria, and then end-stage kidney disease. And then they could have a regression from their albuminuria because these patients are very frequently treated with RAS inhibitors. Then they could be treated with SELT2 inhibitors and mineralocorticoid antagonists. A few of them could have a rapid decline in their GFR irrespective of their albuminuria, and some of them could have non-albuminuric or non-proteinuric decline in their GFR. These are all distinct pathologies. Now, we have significant heterogeneity in the rate of decline of these patients, mainly due to multiple factors which affect the rate of decline. So this study in CJAS, which was published in CJAS, showed that those patients who did not have albuminuria or those patients who did not have hypertension had minimal decline in their GFR. They had almost 1 mil per minute per year, which is almost equivalent to those patients who did not have diabetes mellitus. But those patients who were hypertensive, who have had a previous cardiovascular disease, or who had albuminuria, were very likely to progress to advanced kidney disease and had rapid decline in their eGFR. So how do we define decline in eGFR? We have those patients who are normoalbuminuric, they would have either a very slow decline or around 1 mil per minute per year, or those patients who are albuminuric but not treated would have a rapid decline somewhere between 6 to 12 mils per minute per year, and those patients who were treated with RAS inhibitors, they would have a lesser degree of decline in their eGFR. By rapid progression we define as given by KDIGO, that is kidney disease improving global outcomes. They've defined it as GFR decline more than 5 mils per minute per year. So that's how we define rapid progression of kidney disease in these patients. Now, coming to non-diabetic kidney disease, what is the rate of non-diabetic kidney disease in patients with diabetes mellitus? So we have many studies. Various studies have quoted anywhere between 27% to 69% prevalence of non-diabetic kidney disease in these patients. The variability is because of the selection of the patient, the threshold for doing a kidney biopsy in these patients, and the population which are being studied. So the role of kidney biopsies in type 2 diabetes mellitus remains controversial and is frequently debated among clinicians. Very often we do not wish to do kidney biopsies in these patients, and in actual clinical practice we do not biopsy these patients, and most often they are treated without a kidney biopsy. So what is the data about those patients who are being biopsied? This paper which is being shown here comes from Sanjay Gandhi by Dr. Narayan Prasad and his colleagues. They have done kidney biopsies in more than 530 patients, and they saw that in almost 70% of these patients had some degree of non-diabetic kidney disease. So almost 50% had pure non-diabetic kidney disease alone, and the rest of them had a combination of non-diabetic as well as diabetic kidney disease. So this was a large percentage of the population. So almost 2/3 of these patients had non-diabetic kidney disease to some degree. And they saw that in these patients, acute tubulointerstitial nephritis was the most common pathology. So we can only diagnose acute tubulointerstitial nephritis with a kidney biopsy. It is not possible to diagnose clinically. And this is unlike previous studies where they showed that glomerular diseases were more common, comparable to more recent studies. It is being seen that interstitial nephritis is more common in the more recent biopsy series. In one of the largest series which comes out of the European studies, which was done in Spain, they did biopsies in almost 850 patients. They showed that almost two-thirds of these patients had non-diabetic kidney disease, and these patients were benign nephrosclerosis related to uncontrolled hypertension. So what is the difference in the outcome in diabetic kidney disease and non-diabetic kidney disease? So these patients are shown to have, those patients who have diabetic kidney disease are more likely to require kidney replacement therapy and are more likely to have a higher cardiovascular event. Now, with regard to diabetic retinopathy, what is the predictive value of diabetic retinopathy for diabetic nephropathy? The same study showed that around 45% of the patients with diabetic kidney disease had diabetic retinopathy, compared to previous studies which quoted somewhere around 60%. So this is comparable to current studies. So there is a declining correlation in the more recent studies compared to previous studies. So there's a declining correlation between the two microvasculopathies. And it has been seen that one study done from Shankar Netralaya has shown that those patients who had diabetic kidney disease, diabetic retinopathy was present in 60% of those patients who had macroalbuminuria, 35% of those patients who had microalbuminuria, and only 14% of those patients who had normoalbuminuria. So even pooled analysis and meta-analysis have showed that the positive predictive value and negative predictive value of diabetic retinopathy was 0.72 and 0.69. So what do we have? We have the renal-retinal relation now is, if diabetic retinopathy is absent, then it may be a reasonable pointer towards non-diabetic kidney disease. But the presence of diabetic retinopathy may not be indicative of diabetic kidney disease. So how do we increase the sensitivity of diabetic retinopathy for non-diabetic kidney disease? So how to improve the positive predictive value? So if we choose if you combine the clinical setting with the absence of diabetic retinopathy. So in the correct clinical setting, if the patient does not have diabetic retinopathy, it's very likely that this patient has a non-diabetic kidney disease. Suppose the patient has rapidly progressive renal failure. He or she has nephrotic syndrome. He or she has a nephritic syndrome with absent diabetic retinopathy. Then most likely this patient has a non-diabetic kidney disease. Do a biopsy, we'll get the cause of the kidney dysfunction. What about other pointers towards non-diabetic kidney disease? This study was a retrospective study which was done in more than 240 patients, and it was the retrospective study done from 2017 to 2021. And when they did a multivariate regression analysis, they showed that the shorter the duration of diabetes, that is less than 5 years, the absence of diabetic retinopathy were very strong indicators of the presence of a non-diabetic kidney disease. So also the RBC count, which is active urinary sediment, and negative presence of urinary glucose. So these are some of the indicators that a patient has actually a non-diabetic kidney disease other than a diabetic kidney disease in patients of type 2 diabetes mellitus. So this was a slightly earlier study. So these patients had mostly IgA nephropathy and membranous glomerulopathy, compared to more recent studies where we have acute tubulointerstitial nephritis. So the other predictors of non-diabetic kidney disease is active urinary sediments. So we have RBCs in the urine, RBC cast in the urine. These patients very likely have non-diabetic kidney disease. If the patient develops gross hematuria, sudden and rapid deterioration of renal functions, rapid development of nephrotic range proteinuria, impaired kidney function in the absence of proteinuria or minimal proteinuria, absence of retinopathy, as I've already said, in the correct clinical scenario, or proteinuria with a duration of diabetes less than 5 years. These are indicators that the patient has some form of non-diabetic kidney disease. So what are the types of non-diabetic kidney disease which may be present in these patients? It could be either glomerular diseases or it could be non-glomerular diseases. Non-glomerular diseases are more frequent in the more recent series. As I said, acute kidney injury in the form of acute tubular necrosis, pyelonephritis, ischemic nephropathy in the form of renal artery stenosis, obstructive uropathy. Among the glomerular diseases, we have IgA nephropathy and membranous glomerulopathy as the most common causes. So, since we know that non-diabetic kidney diseases are very common, why do we not do biopsies more frequently? As clinicians, we are really scared of the patients developing a complication. So this is what we get sometimes when we do a kidney biopsy. Among all major organs, when a biopsy is done, kidneys have got the highest risk of having bleeding risk. So 1.2% of the kidney biopsies being done will have a major bleed, which is really scary. Once we have something like this, it really puts you off doing a kidney biopsy for the next few sessions. But a biopsy is required in these patients. So the more factors we have, the lower our threshold should be to do a kidney biopsy. So now coming to a couple of case scenarios which we saw. So this was a 51-year-old female. She had diabetes mellitus for the past 5 years. She was a hypertensive. She did not have retinopathy.
Can you please ask the technical team to focus on the slide, please? They are focusing on your talk.
Pardon, sir?
Focusing on you. Actually, your slides are not visible online. You are only visible online.
I'm not sure. Could you help me out? They say the slides are not visible online. It's there. Slides are there somehow. I'm not sure. It's visible over here on this display, but
in online, only you are visible, not the slides.
What shall I say? Could what do you call he help us out? I'm sorry, just give me a couple of minutes more.
Hello, can you see the slide now? Hello? Hello, can you hear me? Can you see the slide? It is visible here.
Actually, I'm trying to rush through the slides. That's why
okay, please carry on.
Unfortunately being delayed. Can I go ahead, sir?
Please carry on.
I'm sorry, we are unable to help you out. So I'll restart again, sir. Is that okay? So this lady had a significant history of acute kidney injury during the SARS pandemic. She had a maximum creatinine of 4.2 and settled down to almost normal levels. Then she was lost to follow-up. She presented with loss of appetite, and when evaluated, she was found to have a serum creatinine of 4.46 with albuminuria and urinary protein creatinine ratio of 2.5. So a kidney biopsy was done in her. So this showed in the light microscopy there was a thickening of the glomerular capillary walls. Out of 18 glomeruli, 12 were glomerular sclerosed, which is expected. She had an episode of kidney injury in the past, which is a harbinger for chronic kidney disease. And interstitial fibrosis and tubular atrophy was around up to 30%, so there was some degree of chronicity. The remaining glomeruli, as I've highlighted one normal appearing glomeruli, it is not normal. There's a thickening of the glomerular capillaries, and immunofluorescence showed IgG staining along the capillary walls. So this was a case of membranous glomerulopathy. That is why she had proteinuria. When we did the immunohistochemistry analysis, anti-phospholipase A2 receptor was positive along the capillary wall. So this was PLAR2 associated membranous glomerulopathy with progressive glomerular sclerosis. She was treated with rituximab, and she had a partial response with decrease in her albuminuria, and her serum creatinine settled around 1.9. A second case, interesting in the case that he was 48-year-old male, diabetic for 10 years and hypertensive. He had dengue fever in August and documented serum creatinine of 1.2 in August. After he recovered, he continued to feel unwell and developed fever, decreased urine output, and shortness of breath. When he presented on the 15th of September, he was found to be edematous and had acidotic breathing and had to be put on dialysis. On further evaluation, he did not have diabetic retinopathy. He had albuminuria, and urinary protein creatinine ratio was 1.6. Further, he developed anuria and continued to remain anuric for quite some time. And on CT scan found to have features suggestive of acute pyelonephritis. Treated with appropriate antibiotics, recovered partially. He had good urine output, but continued to remain, his creatinine remained stuck at around 4.5. So we did a kidney biopsy in this patient. Remarkable in that he had mild mesangial expansion, expected because he's a diabetic for 10 years, so he has some degree of diabetic nephropathy. He has class 2A diabetic nephropathy. And when we looked further in the interstitium, there was lymphocytic infiltrates, showing that this patient has acute interstitial nephritis. There was a degree of chronicity also. He had chronic tubular interstitial nephritis also. This is a case of class 2 diabetic nephropathy along with acute and chronic tubular interstitial nephritis. He was put on short course of steroids and his creatinine settled back to 1.3 milligrams per deciliter. Very satisfying. So the last case is a case of a 65-year-old male, hypertensive, diabetic for 3 years but not on treatment. He had no retinopathy, albuminuria 2+, and urinary PCR of 2.8. Now his serum creatinine was around 1.22 in 2022, and in 2023 March his serum creatinine was 1.94. But if you look at its eGFR, it has declined from 66 to 38, so almost 30 mils per minute in 1.5 years, which is more than the definition of rapid decliner. As I said, if you remember, I mentioned previously that rapid decliners are those who have an eGFR of more than 5 mils per minute per year. So he has almost 12 to 13 mils per minute per year of decline. So he deserved a kidney biopsy. A kidney biopsy was done in this patient. So if you see the glomerulus, he has, the glomerulus shows segmental sclerotic lesion with mild mesangial matrix expansion with minimal mesangial hypercellularity. So this is a FSGS lesion. When we did the immunofluorescence, this patient had moderately strong immunofluorescence for C1q. So this is a patient of C1q nephropathy with FSGS lesion. So as we know, the C1q nephropathy is difficult to treat. This patient was put on steroids and as well as tacrolimus. He has had a partial response. His serum creatinine has declined from 1.9 to 1.6. Currently his proteinuria is around 900 milligrams per deciliter. Partial remission, not complete. We expect it as such because C1q nephropathy is a rarer entity and is difficult to treat. So these are some of the reasons why a biopsy is usually indicated in patients of when we suspect non-diabetic kidney disease. To conclude, not all patients of type 2 diabetes mellitus diagnosed with chronic CKD will develop renal dysfunctions because of a consequence of diabetes mellitus. It is identification of these patients are essential because the treatment strategies and prognosis are different. We need to lower our threshold for renal biopsies, but it is sometimes very difficult to do a kidney biopsy because these patients are sometimes very sick. So we require more reliable predictors to be able to accurately diagnose these patients from diabetic kidney disease. And absence of diabetic retinopathy in the correct clinical scenario may help us in predicting a non-diabetic kidney disease. Thank you very much.
Thank you, Dr. Gulliver Posangbam. A very interesting topic indeed. Non-diabetic kidney disease along with diabetes, and to differentiate, you have very well explained. This is the last presentation, physical presentation. So we are going to give a concession here and going to open to the house. One question will be allowed to ask. Any clarification? Right.
Thank you, respected chairs, for allowing me to give, because it's a very interesting topic.
as well as congratulations to Dr. Gulliver that he has presented so well, and I should thank him for giving a lucid presentation on this late hours of the day. And often we find many difficulties as a clinician, being because I deal with diabetic patients coming with many deranged renal pictures, and often I get some blast from nephrologists that I should continue conservative treatment or go for renal biopsy to find out whether this is because of diabetic origin or something else. So we are afraid. We are afraid. There are so many problems we face. What is the problem is, one problem is from the patient side, that they don't want to go further for kidney biopsy, number one. Number two is the inertia from the clinicians like us. Number three, the fear psychosis of the complications of biopsies, as mentioned by Dr. Gulliver, because it is risky and bleeding tendency are very much in the field. So I hope I should also take suggestions from you that creatinine of below 2, EGFR of something like 30-40, should I go for that? Number one, for biopsy, which I intend to do it, number one. Number two is that, is it very harmful on the part of the patient to go for renal biopsy? Number three, how are the difficulties that the patients undergoing biopsies on such kind of patients without much of comorbidities, diabetes and a mild kidney renal derangement? Yeah. Thank you, sir.
Sir, so to do a kidney biopsy, sir, we should first test the pre-test probability before doing a biopsy. So if we feel that the pre-test probability of finding a non-diabetic kidney disease is low, suppose we have a patient who is a diabetic for the past 20 years, he has a proliferative diabetic retinopathy, which is strongly associated with diabetic nephropathy. Then even if the creatinine is 1.3 or 1.4 or less than 2, which you said, there's no point in doing a kidney biopsy in these cases, because it's very likely that this patient has a diabetic nephropathy. Second thing is that if the patient has just creatinine less than 2, irrespective of the serum creatinine, if there's a clinical indication, if the clinical scenario fits, then the patient requires a kidney biopsy. Like I've shown the patient of serum creatinine of 4.5, where we did a kidney biopsy. In the correct clinical scenario, we diagnosed acute interstitial nephritis. Now the problem is that I came across a paper yesterday where they showed that if we biopsy every patient of diabetes mellitus with renal dysfunction, we will have in the world, we will have 2 million deaths. That is the extent of the problem. If we biopsy every patient of diabetes mellitus with kidney problem, we will have a total of 2 million deaths. So it is a very huge number actually. So as I've already quoted, it's around 1.2% will have significant bleed of doing a kidney biopsy. The higher the serum creatinine, the sicker the patient, the more likely that the patient will bleed. So it is when we do a kidney biopsy, we counsel very strongly about the possibility of bleed and what may happen. But sometimes it is simply out of our hands because it is a partially blind procedure. We do it under direct ultrasound guidance, but we have had very bad complications, and really it puts you off. A Chelta filter patient comes and we do a biopsy, then patient lands up in a bleed. We may have to do angioembolization, and the patient is still sick. So it is very difficult to convince. So And second upon, many of these patients are unfit to undergo a kidney biopsy. Bedridden patient, we suspect non-diabetic kidney disease, but how to do a kidney biopsy in an old elderly lady who is 65 years old, bedridden for many months. It's difficult to suggest a kidney biopsy in such a patient. The relatives may say that let us not trouble her further. So these are many things which we may feel, and very often many centers are ill-equipped to deal with the complications of kidney biopsies. So kidney biopsies should ideally be done at centers which are equipped to deal with complications. So these are some of the factors where biopsies are less frequent. But in the clinical scenario, as we have seen, kidney biopsies are advisable and are frequently very contributory to the management, and the management is, the results are very gratifying. That's what I would like to comment.
Small comment, it's not a question. We can have nephrolosis. I want to comment a little bit on Dr. K's case is Singh. One of my students doing biopsy on many patients of diabetes. He had done more than 75 biopsies so far in diabetic patients based on indications. But first of the important thing is to allow the contraindications for biopsy, like infections, bleeding tendencies, or whatever else, and we should not have pyelonephritis. Okay, if pyelonephritis is controlled, then you can do it. And many of the patients turn out to be, as Dr. Gulliver had rightly pointed out, many patients that turn out to be having tubulointerstitial nephritis. And some are chronic, some are acute, or acute and chronic, something like that. And very interesting cases of IgA nephropathy are too much is expected. Less, we'll expect less, but it was very much. Membranous in many patients out of 75. And I think, so if we do biopsy in a proper way, based on the various criteria for doing biopsy, I think biopsy is very safe. Ultrasound guided biopsy is very safe. And we are doing very randomly. And frankly talking, it's very interesting. One patient was not having indication for biopsy. Okay. And he was planning for biopsy. There is not much indication. Already talked on many indications. And patient was recovering a little bit, but creatinine was around 2 to 3, and some, say, active sediments in the urine. So, say, having infection or ATI and other things earlier. Then, when biopsy was done, after the problems with ATI and the others are settled, it turned out to be IgA nephropathy, like Chova. So, there are many, he has really pointed out about more than 50%, 70-80% of the cases of diabetic, we suspect the patient of diabetic nephropathy, but there are many cases of non-diabetic renal disease. This is my practical experience. Thank you.
Okay, once again, I would like to appreciate Dr. Gulliver Posangbam for that interesting topic, very lucid. Now we would, the chairperson sitting here on the dais would like to make a call that this session is closed and the evening will start now. Thank you.
Thank you very much. And before we end this last scientific session of today, I would like to request Dr. K. Santibala to felicitate our respected speaker. Ladies and gentlemen, Dr. Gulliver Posangbam. And also would like to thank all our respected presenter, Dr. Samiran Das and Dr. Indira Maishnam. And also would like to request Dr. Medho M. Kotsu, Associate Professor, Nagaland Medical College, Department of Medicine, to honor and felicitate our respected chairpersons. First we have Dr. L. R.K. Singh, our respected chairperson of this last scientific session. Thank you. Next, we have Dr. L. Sarachandra. We have, respected sir, Dr. L. Sarachandra. We have Professor Dr. L.K. Sarachandra, our respected chairperson of this last session, Updates in Management Technologies. Thank you very much. And next we have Dr. N. Somorjit Singh. Thank you. And last but not the least, we have Dr. K. Santibala Devi. And also would like to express our heartfelt gratitude to all the chairpersons who joined us through online, Dr. Swapna Bodhakur and Dr. Samik Dev. Thank you very much. Ladies and gentlemen, as we conclude today's session, I would also like to thank each and every one of you for your active participation and valuable contributions throughout the day. Your engagement has truly made this conference a meaningful and reaching experience. We look forward to welcoming you all again tomorrow for another day of insightful discussions and knowledge sharing. The session will begin promptly at 9 with the poster presentation, and the scientific session will begin at 10 a.m. tomorrow morning. So we kindly request everyone to join us on time. Thank you so much and have a wonderful evening. Pumna Magpo Kurumchari.